type stuff. I'm hoping everyone knows where the bathrooms are down the hall, past registration. You can get up at any time to help yourself to some food, coffee, water, whatever your need is. I'm going to ask all of us to check our phones right now. Make sure that they're turned to silent or off. And you might not know this, but we have participants by Zoom. Are you guys familiar with Zoom? So Zoom technology allows people to join from all over the state of Kansas. So for those of you who are on Zoom, I'm going to remind you to mute yourself. And during the question and answer part with our speakers, if you would unmute yourself if you'd like to ask a question. And even in the chat box, you can let us know that you want to ask a question. You could also, if you don't want to be the one to ask the question, you can send a comment or question to the chat box and we will share that with the audience and with the speaker. If you have any questions while you're on Zoom or any technical difficulties, we have people who are also logged in. We have our IT person here, so if you have questions for him, you can send him a message as well. And so we hope it all goes very smoothly, but we have plenty of people here to help with any issues. I want to take a moment to thank some people who have been heavily involved with the planning of the symposium. We have the programming committee, and under the programming committee, we have the symposium team. Probably the most critical piece of that for us has been the continuing education office with Mary Beth Warren and Joan Fecky. They've been amazing. I cannot thank them enough for all of their time, work, and all their efforts. I also want to thank, we have our faculty lead, Crystal Lumpkins, Fernie Bahena, Monica Holman, Cindy Kim, and of course, Jennifer Keaton. I think all of you know she works to help organize all of the diversity and inclusion events and all of the different committees under the diversity and inclusion cabinet. So she has a lot of work. I want to thank also Sebastiano Procopio and Valerie Salinas Guerrero. They were also on the planning team. And then my team, Stacy Rader, who does all the food and setup, and Alexa Smith, who printed the booklets, who does all of our flyers, pretty much all the printed material and advertising is Alexa. And just a thought for you this morning, when I was thinking about how great my team is, who works with me in the Office of International Programs, they buy in to whatever my dream or vision is. And there's a part of that is directly connected to diversity and inclusion. We have to buy into each other's dreams, so much so that when there's an obstacle or something in the way of someone's dream or someone being included, that it means as much to us as it does to them. And my team has really taught me a lot about that. On that note, I'm going to ask Dean Akinwantan, he's the Dean of the School of Health Professions, to come up and give us a quick welcome on behalf of the university.
Good morning. So, during the summer 4 years ago, the Executive Vice Chancellor at the time, Dr. Gerard, who is now the Chancellor of our university, had a vision of diversity and inclusion. And he had a vision for a diversity and inclusion cabinet and a programming committee. He saw a gap that had been created and the need for issues related to culture, diversity, to be connected to clinical care and research. At that time, the Tilford Conference on Diversity and Multiculturalism was offered and supported by the region schools. But its undergraduate traditional campus, the focus lacked in material directly related to the medical center. Dr. Gerard had a vision for a conference or symposium that would be relevant for healthcare providers, educators, and researchers here at the University of Kansas Medical Center, as well as our neighbors who are partners in delivering healthcare in Missouri and Kansas. So this symposium was born the very next spring in 2017. The first symposium focused on refugees in the health system, followed by palliative care and pain across cultures, and our third symposium today, health literacy. Each year, the programming committee asks a University of Kansas Medical Center faculty who has expertise in the topic to lead the symposium team. The first year, Dr. Martha Baird and Dr. Joseph Lemaster formed the content of the symposium. The second year, Dr. Christian Sinclair was lead for palliative care, and this year, Dr. Crystal Lumpkins has been the content lead. We want to express our gratitude for their expertise and guidance. Again, I've been the dean for 3 years and I'm in my 4th year, and I have seen very practical efforts by this institution and the leadership of the University of Kansas Medical Center to grow diversity and inclusion. And I am not surprised that Dr. Girard saw the focus of other schools not being directly related to the medical center and decided to create this symposium. Healthcare is still one of the areas where diversity needs to be entrenched. And whatever things you discuss today during the symposium will go long ways to make that happen. Diversity, inclusion, and I say retention as well. I wish you all the best with your symposium and have good deliberations. Good morning.
And I'm back. I want to take a moment to thank those people who are joining us by Zoom. We have people from Children's Mercy, the KU Health System, Kearney County Hospital in Lake, Kansas, and Providence Medical Center. At this time, I'd like to introduce our Health Literacy 101 speaker, Dr. Christy Haddon. She's the founder, executive director, and principal investigator for the University of Arkansas Medical Center for Health Literacy, where she leads and conducts health literacy research and participates in initiatives to address health literacy in Arkansas. She is an associate professor in the UAMS College of Medicine and also holds secondary appointments in the colleges of public health, pharmacy, nursing, and health professions. In 2015, Dr. Haddon was awarded an NIH R01 to study health literacy and diabetes among rural primary care patients at UAMS regional centers. She has served as vice chair of the Partnership for Health Literacy in Arkansas and as an honorary fellow of the Arkansas Society of Public Health Educators. Dr. Haddon holds a bachelor's degree in communication sciences and disorders from Radford University in Radford, Virginia, and a master's degree in speech language pathology from UAMS. She practiced as a speech language pathologist and augmented communication specialist, and then earned a PhD in health promotion and prevention research at UAMS. Dr. Haddon enjoys traveling and outdoors, especially with her family and their dog. Please join me in welcoming Dr. Christy Haddon for Health Literacy 101.
Good morning. Yeah, you can hear me. Thank you so much for having me here today for this symposium. I really enjoy coming to Kansas City. I'm going to talk a little bit this morning about Health Literacy 101, very introductory sort of content. So for those of you who are experts already in health literacy, maybe you can just be entertained by my Southern accent every once in a while. I will try to be as animated as I can. But I'm going to get started and talk a little bit about where I'm from. But it's not good. All right. There we go. Okay, so I'm from Arkansas, and that is a picture of our campus at the University of Arkansas for Medical Sciences. And I did some research on your medical center and this institution and found that we have a lot in common. So I am a researcher. I work in education and a little bit in the clinical enterprise and research all three areas. And I'm privileged to do so. And so we have at UIMS a College of Medicine, a College of Nursing, a College of Pharmacy, a College of Public Health, a College of Health Professions, and a graduate school. We train the vast majority of health professionals in Arkansas. Arkansas is a rural state. We have very, very, very many underserved areas in Arkansas. So the UIMS is very important to the health of Arkansas. And fortunately, because of where the Center for Health Literacy is positioned, we serve the entire institution. So we have faculty in all of the colleges. I have faculty appointments in every single college. I work with researchers and learners regardless of their discipline. And that is very, very important. We have centers for excellence. We have a cancer institute. So a lot of these things that I was hearing when I was learning about your medical center and about your institution, we have a lot in common. So I want to talk a little bit about health literacy. I'm going to start this morning about just 101 basics, and then this afternoon take a deeper dive and talk about using health literacy as a lever. I'm going to end my talk today with hopefully some thoughts to carry forward and maybe a little bit of suggestions for you to take back to your work, regardless of where you're going back to work. Can I just ask all of you, how many of you work in education with learners? And how many of you work with patients in the clinical area? What? Okay, and research? Wow, this is like a beautiful split. Okay, great. Okay, so I'm going to start with talking about an introduction to health literacy as a concept, and then move on to why that matters. Why do we care about health literacy? And then something new I've added to my slide deck is the history of health literacy. When I started working in health literacy was kind of new. And now we can actually look back over the history of health literacy and how it's developed and how it's the state of the science. And we're going to look at it decade by decade and see how it's changed. And that will sort of bring us up to speed for the state of the science of health literacy right now. And then transition into health literacy competencies, things that we all can be and should be doing for health literacy and health literacy best practices. And then end with some thoughts on health literacy and unconscious bias. So, health literacy. I like to say this is not the best definition of health literacy, and it's not the worst. I don't even know if it's my favorite definition of health literacy. There are a lot out there. My colleague and friend Andrew Pleasant did a study one time and found there were 26 published definitions of health literacy. But this is the one that you see probably the most. This is the definition that's been sort of endorsed by the Institute of Medicine for many, many years. What I do like about this definition is it calls out some specific skills of people. This is a definition for individual health literacy, the health literacy that a person may possess. And it separates these skills out into the first skill that a person needs to have health literacy is to obtain health information. So those are skills in finding health information, which are different than the skills that a person has to process that information. So processing is difficult to explain. The way that I like to explain processing is, imagine if you were in an art gallery or a museum and you're looking at an impressionist painting, a very large impressionist painting, and you're standing very, very, very close to that painting. What would you see? You probably just see splotches of color in front of your face. But if you step back, every time you step back, those colors start to come into some kind of organized, they start to make sense. Slowly but surely, you step back, and then there's that moment where, aha, you see what it is. You step back far enough, you've processed all that, you've sorted it, it makes sense, and now you say, oh, water lilies, or whatever it is. That is sort of what processing is. So just because you can find it, doesn't mean that you can sort it through all these filters, evaluate it, and make sense of it. And then the last skill is understanding it. And that's where you take that information, so you know what it is, but how do you make it meaningful to yourself, to your own life? That is the key to understanding health information. And so health information here can be interpreted very, very broadly. So it's not just what you read in a health brochure. Health information is on the internet. It's in communications with your providers. It's in communications and conversations with family members. Health information is everywhere. Nutrition labels when you shop, right? So it puts health literacy in this very, very broad context. But working in the sciences, I like to call myself a scientist, we like to take things apart. We like to stick things under a microscope and look at all the different parts. So when we pull health literacy apart, there are different components of it. And the first is prose. So a person needs to be able to read in order to have adequate health literacy, because so much health information that's given is written. And so prose literacy is what you probably think of when you say the word literacy, and that is the skill to read text from left to right, up to down, in continuous form, all these words connected in sentences, sentences connected in paragraphs. That's prose literacy. Document literacy is a little different though, and it employs a different set of skills. So in document literacy, you've taken words, maybe in a paragraph, and you pulled out a few of them and you put in blanks, and now you have to fill in something in that blank, like in a form. Or you've taken words and you've drawn pictures everywhere, and you have to use your spatial skills because they're on a map. Or instead of reading left to right, up to down, the words are in a chart where you have to read across a row and match it up with a column, right? That's a different set of skills than just left to right, up to down. And so, of course, document literacy is very important in health information. Numbers. So there's quantitative skills that are absolutely necessary for health literacy, especially if you are managing a chronic disease and you have to do things like count carbs and titrate your medicine and keep up with multiple dosing schedules at different times and different amounts. And then just understanding risk to make your own health decisions, understanding risks and benefits of perhaps maybe getting your opioid prescription filled. Numbers are critically important as well. And this one, I have a problem with this. The label that you see a lot is oral literacy, oral health literacy, but being a former speech pathologist, I really know what they mean is verbal, because oral means mouth, and I don't think they mean mouth health literacy. But verbal health literacy is all about the interpersonal and group conversations that happen without print, without text, without that visual information, but with verbal language. And then lastly, digital. So digital skills, we're expecting people and patients more and more every day to interact with their patient portals. We're expecting people to fill out online forms and information and all of these things. So the digital skills that people are expected and essentially required to have for health literacy now compared to 10 years ago, there's been a dramatic shift in that as well. So I just added this graphic so that you can see the different kinds of components represented in one piece of health information. So in this, you can see there's a little bit of prose, because there's some continuous text in there where you have to read left to right, up down. But then also there's percentages there. So there's numeracy. Definitely, if you don't read this from left to right, up to down, you can kind of jump around. So it's arranged in a document literacy kind of fashion. So all of those components interact with each other in health information. But so why do we care? Well, we care because low health literacy is a problem. I'm going to talk about that problem a little bit. We know from years and years of research that low health literacy is associated with less of the good things about health, more of the bad things about health. So low health literacy on a patient individual level, we know is associated with less preventive care. So patients with low health literacy are less likely to get their flu shot, mammograms, screenings, those kind of things, have less knowledge of their diseases. Patients with low health literacy are also more likely to be hospitalized and rehospitalized. So readmission rates are higher in patients with lower health literacy, higher mortality in this population, and all of these things translate to incredible healthcare costs. So costs for avoidable care, avoidable services. We don't have a lot of current health literacy data from as far as national survey data. Researchers are out there waiting for new national survey data, please. But our latest national survey data show us that health literacy is a problem on the national level. So in this graphic, you can see the green are about 12% of people in the U.S. have proficient health literacy. We really want everyone to have proficient health literacy. Proficient health literacy is what really everyone needs to be healthy and to stay healthy, regardless of whatever diagnosis comes your way. Have this according to this national survey. But what's really alarming are the bottom two colors, the blue and the red together. So that is basic and below basic combined. So basic and below basic combined shows us that 35% of Americans fall in this category. The reason that that is so important is that first, that's a big number, a big proportion of our people, but also those skills are not adequate to manage a chronic disease. And we know that chronic disease is a big problem, especially in our older adults. So it's a double-edged sword here. There's a lot of people that have basic and below basic skills. Those skills are not adequate for the problems that face most Americans. So a few more statistics, and these just show you some examples of what these different category tasks might be. So a below basic skill is identifying how often to have medical tests, based on something that you're given in a clinic office. And then basic would be just giving 2 reasons a person with no symptoms might be tested for a disease. So that's pretty simple, a simple task. Intermediate is like reading an immunization chart, which those of you with children, you've had to do. Knowing at what time your child is supposed to have which shot at which age. And again, that's employing a lot of document literacy too, and those charts and percentiles, those kind of things. And then proficient has to do a lot with insurance, calculating your copay on a sliding scale. Those kind of things are examples of proficient skills. So quick quiz. Which of the following is the best predictor of an individual's health status, according to a 1999 JAMA report? Probably since I'm the one who's standing up here, you know the answer to that is literacy skills. And this is based on some research by Dr. Weiss that showed that 75% of people who reported being in poor health also tested in that low health literacy range. So who struggles with health literacy? We know, again, from years and years and years of research, that older adults are at higher risk for lower health literacy. Again, that's a big problem because we know that older adults suffer from chronic diseases. They consume more care. They actually need more health literacy. They need higher skills. And that is for a lot of reasons. So older adults, they have lower health literacy because of cognitive decline, because of sensory decline, for a lot of reasons. And then low education. So people who live in areas where they don't have access to good quality education are more likely to have low health literacy. Those with chronic diseases, low income, and minority race. But the real problem is that
that we don't know, or we don't always know, if the person in front of us, the person that we're trying to help, has low health literacy, especially in clinical encounters, because we also know that patients with low health literacy are less likely to ask questions. So those individuals who need to ask more questions are asking questions less. And this has implications of inadequate health literacy. I'll use inadequate health literacy, low health literacy, and limited health literacy, all sort of interchangeably because it all depends on the study that you're citing. But generally, we mean low health literacy. So again, when patients don't understand what they need to do after they leave the hospital, or what they need to do to manage their disease, they're given too much information that is difficult to understand. They're more likely to present to the emergency room, more likely to have medication errors, a lot of serious medication errors. They're more likely to skip screenings and shots. Again, they're less likely to engage in preventive health services. And then all of these translate to higher healthcare costs. But I want to talk about the real problem with health literacy. So I've been talking about things that people need, that individuals need. But that's not really the problem. So health literacy has two sides. I've been talking this whole time about the individual skills that a person, needs to have health literacy. But that's not the problem. The problem is not that people don't have skills that they are supposed to have. The problem is that the demands that are placed on the individual are just too great. And so the demand side of health literacy is really important. And that's where we exist, most likely, probably. So the demands are, having a complex health system to navigate. That's a demand on a patient's skill. Having a chronic disease where you do have to make daily lifestyle decisions and measure risk and keep up with demands. Having information that's difficult to understand, that is a demand. And so the analogy that I like to tell a story here to demonstrate this difference in skills and demands. So my grandfather, when he was young, he picked up, now I'm older than probably a lot of you in the room. My grandfather's probably older than your grandfather, but when he was young and he was sick, he would pick up the phone in Arkansas, and his doctor would come to his bedside at his house. His doctor would grab his bag, show up at his house, go to his bedroom, open his bag, pull out his stethoscope, examine him. They would talk about some things. He might pull out a bottle of pills or medicine or something and give them to him. When it was all over, there was some exchange of payments. I don't know how that worked. It was like a goat or something. I don't know. And then the doctor would leave, and then he might call him a couple of days later and say, hey, how are you doing? So compare the skills that my grandfather had to have when he was young to get care to, well, and first of all, he only sought care when he was sick. There was no preventive anything. But so when he was sick, compare the skills that he needed to have to manage that to when he was 71 and had type 1 diabetes and heart disease and had to navigate 7 different specialists, was hospitalized frequently, was in and out, bounced around, emergency room, admitted, rehab, home, back to emergency room, back inpatient, back to rehab, over and over again. And the skills that he and my grandmother had to have, they just couldn't keep up. So was it his fault? So what we can do as working in health systems and working in research and working in education is to work to put that seesaw in balance, right? We need to help people to develop skills for sure, but we also need to lessen the demand on those people. So here's our little timeline. I'm going to talk about health literacy in the 70s and 80s. So it was really fun when I first started working in health literacy. It was this new field. It was a nascent field, and we used to always, lament, oh, if we only had more research, if we only had more research. And now we look back and say we actually have a pretty robust history. The first mention of health literacy was back in the 70s,
And the work around health literacy was really trying to figure out what is the difference between general literacy and health literacy. And is this a thing? Is there a difference? And if so, what is that difference? Again, is this even a thing? So then in the 90s, we picked up a lot of momentum. And that's when the first National Adult Literacy Survey, the NALS, was conducted. So we have a national data set and results. That's when we started looking at things like, oh, here's how it's different than general literacy. It has these components. We need to look at how well people can manage prose literacy and then also document, and oh, guess what, numbers are important too, which is different than in general literacy. So then also in the 90s, we got our first measures of health literacy. So the rapid estimate of adult literacy in medicine, the REALM, was developed by my friend and colleague Terry Davis in Louisiana, and then followed by the test of functional health literacy in adults was developed by Ruth Parker at Emory. So we had a way to measure this thing that we had defined a few years before. And so that's when research started happening. In the early days, there were a lot of readability studies. I think people who believed that health literacy was important, they really, while they were seeking to measure it on this individual level, the research was really on the demand side. I don't think they realized it at the time, but in an effort to do something about it, they did this environmental scan, and they said, okay, well, if people have a hard time with this stuff that we're giving them, how do we measure the stuff that we're giving them? And so there were all these readability studies. So that's when you see all of these things that say, you know, this was written at a 14th grade level or college grade level. And so it started to highlight, we need to make some changes to put the communication that we're giving our patients in alignment with what we're measuring their skills to be. And that's also when that very strong statement came out in the Journal of the American Medical Association that poor health literacy was actually a stronger predictor of health than these other that we've been citing for many, many years. So then the 2000s came along, and has anyone seen this book, this Prescription to End Confusion? So it was a very, very important book that came out from the Institute of Medicine at the time, and it brought together the definitions of health literacy. It talked about the data that we had at the time, the scope of the problem, and some things. It started pointing towards developing best practices and setting up a research agenda for further research. And then a new measure was introduced, the newest vital sign, which I'm going to talk a little bit more about this afternoon, that gets a little bit more at functional health literacy skills. And then the next national literacy survey and results were released in 2006. So we had some updated national data. And then the Joint Commission starts to chime in and says health literacy is important, and it's important to patient safety. So we have the clinical side of the house starting to speak up here. And then later in the 2000s, that was when we really started I feel like the science of health literacy really started to take off, because we shifted from this whole, let's do these readability studies, is this hard or difficult to understand? What is this patient's health literacy compared to this patient's health literacy skill level? And they started thinking about why does this matter in terms of health outcomes? If what we really care about are health outcomes, what role does health literacy play, and where is it in this grand scheme? So that's when these conceptual models came out. So here's this one. I don't expect you to read it, and I'll talk more about it this afternoon. But that's when scientists started looking at causal models, conceptual models, and building the case for creating interventions for health literacy. And so then the big research at this time was, in fact, focused on health outcomes. So that's when all those studies came out that said health literacy is associated, low health literacy is associated with fewer flu vaccines. Low health literacy is associated with higher mortality. Low health literacy is associated with, higher readmission rates, all of those. Then in 2010, I think was the big health literacy boom here. Like a big explosion happened in health literacy in 2010. Again, I was around then, didn't really realize it was happening at the time, but now looking back, it was such an important year because health literacy was included in Healthy People 2020. So it was a national priority now to do something about health literacy. The National Action Plan to Improve Health Literacy was developed. Again, another national effort focused on health literacy and really getting at that reducing demand on the other side of health literacy. And then NIH comes in and put their money where their mouth is. So NIH says, we're going to fund research on health literacy. So this program announcement was released in 2010, and it stayed around for a number of years. In fact, my R01 is funded under this program announcement. And so there were, I forget how many agencies signed on to support and fund health literacy research. I think at one time it was like 20 agencies in NIH were interested in funding health literacy research. And so that's when we really had a giant boom in health literacy research and articles, with over 2,000 articles in PubMed at that time. So where are we today? So as I said, the first part of our history in health literacy was really all about what is this thing? So it was really about definitions. Then we wanted to, once we decided, we sort of agreed what is this thing, we decided we needed to measure it. So we developed measures. Then we started doing research on, okay, we've measured it. Now, what does it mean in this situation? What does it mean in this situation? How can we develop some research that's meaningful to practice? And then where we are today is we need to do something about this in practice. We need to demonstrate. We have, a friend of mine says, we have admired this problem long enough. And so let's do something about it. And so now it's all about interventions. So I'm going to introduce this idea and talk a little bit more about it when we do our deeper dive. But another thing that's different, I think, about health literacy today compared to 10, 20 years ago is that the way we talk about it. So we have talked about improving health literacy for a long time. Now we talk more about improving health, because at the end of the day, what do we really, really want to do? Do we want to improve someone's skill level for the sake of improving their skill level? Do we want to reduce demands just to reduce demands? Or do we want that to be meaningful for a health outcome? I think what we're all here to do, and the reason that we go to work every day, is to improve health. And so we're positioning health literacy a little bit differently in our conversations than we used to. And we talk about improving health outcomes and improving health by addressing health literacy. And that is because, again, because of where health literacy is in these causal models. It's not the outcome, it is the lever. Okay, so the last part of my talk today, I want to focus on hopefully some things that you can take back with you, do, and help others to do that you work with. So I'm going to talk about doing something on that demand side of health literacy. And I want to focus on health literacy practices and competencies. So my very good friend and colleague, Cliff Coleman in Oregon, has dedicated his research to, his research is educational research, and he's dedicated it to identifying competencies that all health professionals should have related to health literacy. And he's been doing this for many, many years. And so he has focused, identified competencies that are in the areas of knowledge. There are things that we all need to know about health literacy. There are things that we all need to be able to do and to demonstrate. And then there are attitudes that drive how we do these things in practice. And we have strong rationale for doing these. These are just all cited studies that say that unfortunately, healthcare professionals, they don't have these things. in history, as we've come up through history and we're training our health professionals, they're not necessarily being trained in these things that provide them with the adequate knowledge, skills, and attitudes to do these things in practice. And at the same time, we have curricula. We have people out there saying, well, here are some things that they should know. Here are some things that we should do. A little bit of research has shown that training is effective, but we really just need more research. So Cliff Coleman set out a few years ago and said he did this consensus study where he interviewed lots and lots and lots of experts. I think he used a Delphi process to identify 33 competencies, 33 things that health professionals should do to address health literacy with patients and people. Then his follow-up study to that is he took that, knowing that asking any college or any school program to integrate 33 competencies into their curriculum map was going to be pretty darn, that's a hard sell. He went back to a large group of experts, and I got to participate in the study, and we did this really cool thing called Q-sort, where you prioritize, you have some researchers nodding your head, it's a really cool thing. You prioritize things, and things are on index cards, and you do this sort of normal distribution thing, and at the end, you can very easily see which things are the most important. And so these competencies rose to the top, and there's 8 of them. So 8 is a much better number than 33 when you're trying to do something, especially when you're trying to educate learners, demonstrate competencies, move the needle on that demand side. You can really focus a lot of efforts on 8 things. So I'm just going to quickly run through what these 8 priority competencies are. Hopefully a lot of them will ring a bell with you, or will just be very intuitive. Like, of course, yes, of course, that's a priority. We all need to be doing those things. And the first is to routinely use teach-back. And I'm going to do a little bit of a teach-back demonstration. If you've seen 100 teach-back demonstrations, I think there's always room for one more to use teach-back. And that is confirming understanding by asking the patient or the person to repeat back in their own words what they have heard. Consistently avoiding jargon. Of course, that's a very important thing to do. Eliciting questions, not by saying what questions do you, not by saying do you have any questions with your hand on the doorknob, but eliciting questions by saying what questions do you have. Using a universal precautions approach, meaning do these things, do them all the time, do them with every patient, especially if you don't know if they're struggling. Making sure that information is provided in the appropriate language. Duh. Yes. Focusing information on the need to do things rather than sort of the need to know, and consistently eliciting a full list of complaints. That's all about agenda building, right? So I have this fun video that demonstrates the importance of teach-back. I think some of you have seen it. Right, so I'm not sure that House is always the best communicator, but he did an effective job of teach-back there. And so we have lots and lots of reasons to do teach-back to confirm understanding. There's lots of evidence behind this. You're welcome to look up these studies. They'll be in my slide deck. This shows you the loop, where if you're going to do a teach-back, you start by explaining something. The critical part is this little feedback loop in the middle. So you're assessing and then clarifying, and assessing and clarifying until you get to understanding. So it's very important that we don't just skip from, we're not going to explain it, say, do you understand, and move on. You really want to assess and clarify. The way that we train our medical students, our pharmacy students, to initiate a teach-back is to take responsibility for the message. We're constantly wanting and focusing on avoiding blame. What you don't want to do is test the patient. You don't want the patient or the person to feel like they're being tested. What you really want to do is say, how well did I do in that communication? So you take responsibility for the message, saying, you know what, I just want to make sure that I explain that. We covered a lot of things, or this is really important. I want to be sure that I did a good job of explaining it. can you tell me in your own words, what will you do when you go home? Or show me how you're going to use your inhaler before you leave. Or what will you tell your husband when you get home? Some other things that you can use, visual aids, demonstration. I'm a big fan of drawing pictures, because drawing pictures not only gives people more feedback, it lets them use a different set of skills, and it also allows them time to process. So as you're drawing, people can see how this is connected to that, is connected to that, is connected to that, and that whole impressionist painting has time to formulate in their head. And the last one is pause. It's worth it. We need to give people time to process, time to understand. So I'm going to leave you with some thoughts about health literacy and unconscious bias. I'm not an expert in this by any means, but I challenge you all to think about these things. As we go through this day, you're going to hear lots of great, there's panels and talks, and we all need to think about how health literacy is meaningful in the space. How can we use health literacy not just as a lever to improve health outcomes, but as a means for health equity and for eliminating bias, all of these things. I don't know the answer, but I'm hoping that maybe you all can help us get there. So in summary, health literacy is complex. There are things that we all can do, and we need to take responsibility for both sides of that seesaw. So I've covered a lot of information today. What questions do you have? And our Zoom participants too.
Thank you for that great presentation. I'm curious about the surveys to measure health literacy. Can you just describe generally what are those types of questions and how do they arrive at these conclusions about percentages that are at these different levels of health literacy?
That's a really good question. So for the national survey questions, just finding out what those questions were, I mean, you talk about a rabbit hole, like finding out. They're not readily available, but they did. They were validated. They did some psychometric testing on them. I don't recall what they were. Again, this was in the early 2000s. You know, so we're talking almost 20 years ago. And that was developed by, I think, the NEA, I believe. And so it was all in this education space. So people who had been surveying for general literacy for years and years and years added 3 questions, I think, on health literacy to come up with those. So there are limits to how we interpret those. It's all we have for national data sets. Okay.
I have the
You two duke it
microphone
out.
over here, and then as I'm talking, I will walk towards you. So I just want to remind the Zoom participants that you can put a question or a comment in the inbox or the chat box. Also, Dr. Haddon, I had a question about, you talked about the determinants of health being health literacy, and we were choosing between education, socioeconomic status. Can you talk a little bit about how all of those feed into the health literacy, though?
I can, but I have about 7 slides this afternoon on it.
Okay, we can hold it till this afternoon.
Okay.
Perfect.
I'm going to talk. Yeah, I'm going to talk about.
Patient.
Okay, I'm going to talk about what contributes to health literacy
Perfect.
and also how health literacy fits into social determinants of health.
Perfect. I love that.
Stay tuned.
And then just a comment. I really appreciated when you were talking about like a practitioner, and rather than saying, "Do you understand?" Because I work with internationals, so for 30 years, I've been working with people who sometimes speak another language as their first language. And that's a real pitfall to fall into, to ask someone if they understand, because even if you ask me, I'd say, well, I understand something, but rather asking me to speak back or to put it in my own words, what was told to me allows me to think about what was said and to process it and put it in my own words, and then you can give me more feedback on what I understood.
Hi, good morning. I have a question about the instruments to measure nutrition literacy. I work with nutrition, that's
Okay.
fine. Health literacy, because most of them are always measuring document and region literacy. I wonder if there's something out there measuring image literacy as well, because also when you see an image, does not necessarily mean you recognize and understand what that means. So is there any research going towards more through image literacy as well?
Not to my knowledge. That's very interesting, and I completely agree with you. I think that is that's very important, and I'm just thinking about some of the early studies that Terry Davis did when she really was the first, one of the pioneers in health literacy research, and her research really kind of got at that issue, because what she did is she had this sample of patients who were on a medication, and it was a very simple take 2 twice a day or something like that, and it had all these labels about, don't drive with this, or watch out for the sun, or I don't know, all these. And she did the series of studies, and it turns out people do not understand those pictures at all. And it was hilarious, some of their interpretations of what these images were. So it's very important to health literacy, but I don't know a way that we've come up with a way to measure that kind of discrete skill or component. It's just usually folded up into document literacy. You're right. Why don't you develop that measure? That'd be great.
We are working on nutrition literacy, so.
Okay, great.
Yes, a couple of questions. I know that the Kuttner article was published in 2006 from NAL data collected in 2004, correct?
I think so.
Is that right?
Or maybe 3.
But the thing is, there's been nothing collected on a nationwide level since then, right? And our population has grown dramatically since then. We now have a much older population as a percentage of the population. Has there been any sort of work done in trying to remeasure health literacy?
Amen. Amen. Amen is what I have to say. And so especially when you consider, like, we had a national priority to do something about health literacy, and we expected to improve it. We included it in all of those national in 2010. So, hey, it's been almost 10 years. Like, let's measure. Let's see what our impact was. And the answer is not that I know of. Not that I know everything. But there are some things happening internationally. I know that there is this push towards looking at health literacy on an international scale. And so collecting data internationally, so we can not just benchmark, the United States, but we can look at health literacy across. To me, that's difficult, because I feel like the United States, because our health system is different, because we're different in so many ways from the other countries that we would be, compared to. I kind of wish they would just repeat the nows and do a better job. But I don't even know what's behind that. Again, I'm not connected in those circles to find out why. I just know that researchers like me just cringe every time I have to cite that study that's so old.
Same here. I cited it in my lib review.
Oh, right.
So,
I'm sorry.
My other question. Right now, I'm working at implementing a nutrition literacy screening tool into outpatient practice. And I know that there are multiple health literacy tools, all objective, all validated, some of them incredibly short, like the NBS and the Realm. What's the actual use of these objective measures of health literacy in actual daily clinical care?
That's a great question. I'm going to talk a little bit about that this afternoon, but not a lot, because mostly I was going to talk about screening. So the measures, it's a little controversial, because there's a school of thought that says you really shouldn't be measuring something, comprehensively if you're not going to do something about it, if you can't do something right then and there. So measures like I know the realm has been used in clinical practice, though not a lot. They're generally used in research. They're used so we can measure something and draw some lines, some conclusions that are meaningful so we can do something about it, but it's under a research protocol, generally, what all the measures are. Until Lisa Chu came around and said, you know what, we need to develop easy screening questions that are just, there's no right or wrong answer, but we can map them to these measures through validation studies. So there's, you know, Lisa Chu came up with these list of questions, and that's actually what we use at UAMS and at Vanderbilt for in clinical practice. So there are questions like, how confident are you at filling out medical forms by yourself? And there's 5 response options. And if you respond to lower 3, then these validation studies say that you are at risk for having failed the NVS had we given you that test. So it's a predictor of how you would have done on a measure. The measures, we really just use them for research. We don't use them in clinical practice a lot. So that's, I think, the importance of having these screening questions. And that's a beautiful segue to what I'm going to talk about this afternoon, so thank you.
Hi, Christy. We have a question from Zoom.
Okay.
With the relatively new national emphasis on health literacy, is there any push toward addressing health literacy at the grade school level? i.e., are grade schools offering classes in health literacy?
So part of the national action, a big part of the National Action Plan to Improve Health Literacy included K-12 curricula development, focusing on the entire lifespan. You know, anytime you want to move the needle on something big that affects a lot of people, the ideal time to intervene, how do you figure that out, right? Because, you know, if older adults have a big problem, well, could that problem have been prevented younger in life? You know, you go back to, oh, well then, you know what, it really comes back to prenatal care. You know, it really is, we really need to be intervening across the entire lifespan if we want to do something about health literacy. And so in childhood, if you do not have an opportunity to develop health literacy skills in childhood, kind of miss a critical window. These things are very, very difficult to develop later in life. So including it in school and high school and elementary school curricula is important. I don't know which states are doing, like, that are the rock stars in that space. I would like to know. We work with our Department of Education some in making sure that we have quality health curriculum in the schools. But again, fighting for space in the curricula is really, really, really hard. So we have to focus on why this is important. And here's how you can do what you're already doing better. So for instance, in high school health classes, let's teach insurance literacy. You know what? All of these kids are going to have to, at some point in time, and some of them sooner than they anticipate, are going to have to manage their own health insurance. And if they don't have insurance and they don't have good access to care, they don't have good access to care, they're not going to have access to prevention and all the things that are going to keep them healthy. So it's really, really important. You need to be teaching this in health classes in high school before these people become adults, because unfortunately it's not really a class that we get as adults. So I think there's great opportunity to do more in that space.
That's great. And I just want to add that as a child, my brother was diabetic. And so I grew up very young reading the labels on all the food. And so I feel like I had a great advantage over a lot of people my age. Mm-hmm. I'm 51, so there was no Googling, you know, anything. And so my mom was really good about instilling that in us. At this point, Dr. Haddon, I'm so glad we get you back because I know there's still questions and comments. I know even I have them, so we'll have an opportunity to engage with you again and throughout the day. Some of these questions might come up again. I'm going to pass the microphone over, excuse me, to Jen Keaton as she introduces our next speaker. And I just want to reiterate to everyone, if you need to get up, take a break, get some coffee, go to the bathroom, do so whenever you need to do that. And our Zoom participants, we know you're there and we're grateful for you. We'll be looking for your comments and questions in the inbox.
Good morning. We do have a few minutes to take a little break and get set up, so if you need to use the restroom or get some more coffee, just give yourself a couple minutes. We're a little bit over time, so we are starting just a little bit late, so we will get going as soon as possible. Thank you.
Have a panel?
Yes.
All right.
It makes me taller.
Nearby. Use podium line. We have slides. But yeah. Me too. I thought it was going to be something. Yeah, that's what Crystal, see if your mic works. Press the button, see if it's blue light comes on.
Yeah, is everybody on? Yeah, great.
You're so welcome.
So questions kind of throughout, have you guys decided?
It's gonna be,
Okay, yeah, that's
Crystal
good.
is gonna be leading, so what you're thinking is just open
It's
discussion
gonna be,
about
yeah,
health.
oh, perfect, yeah.
And did they tell you how to use the content about going on?
Yes.
Okay, it looks like we have most people back, so we will get started. My name is Jennifer Keaton. I'm in the Executive Vice Chancellor's office. I'm the Director of Special Programs and Strategic Initiatives, and so I help with our Diversity and Inclusion Initiative. And I'm just so happy to see a great mix of people here today, familiar faces and new faces, so it's wonderful, and we appreciate you being here. So the next part of our program is a research panel discussion, and the way this is going to work, I'm going to introduce our moderator and participant, Dr. Crystal Lumpkins, and then she will introduce our other panelists. They will each share they'll do kind of a question and answer format, and then we'll take questions again at the end. So at this time, I want to introduce Dr. Lumpkins. She's an associate professor at the University of Kansas Medical Center in the School of Medicine in the Family Medicine Research Division. She's the assistant director of the resident research program, and she also holds a courtesy faculty appointment with the Department of Preventive Medicine and Public Health and the William Allen White School of Journalism and Mass Communications and the School of Social Welfare on the main campus in Lawrence. Community and patient engagement are a core part of the Department of Family Medicine's research division, and Dr. Lumpkins conducts her research in that area, primarily in comparative effectiveness research, medical education, communication, health literacy, and evidence-based health communication targeted to minority and underserved populations. Dr. Lumpkins' research is primarily community-driven, where she follows community-based participatory research principles and approaches Kansas and Missouri patient populations to address health inequities and cancer disparities. Dr. Lumpkins received her doctorate from the University of Missouri-Columbia in 2007. She holds a dual master's in media communications and management from Webster University in St. Louis, and she is our moderator and participant here today on the panel. Dr. Lumpkins.
Thank you so much, Jennifer. I really appreciate that. Again, my name is Crystal Lumpkins, and I'm excited to be here just to talk about some different perspectives under that health literacy umbrella. And I'm so happy also that I have the panelists here today to discuss this, the role of health disparities in health literacy. So without further delay, I'm going to introduce my esteemed colleagues. Joseph Pacheco is an American Indian Latino researcher at KUMC pursuing a PhD in health policy. He received a Bachelor of Science in Pre-Profession Zoology from Northwest Missouri State University in Maryville, Missouri. After graduating, he was unsure of his next step. Mr. Pacheco knew he wanted to help others better their health, but was not sure the best route for him to do so. So after talking to his family, some of his family members are here, I believe, today, trusted advisors, Mr. Pacheco knew that pursuing a Master of Public Health, MPH, would best suit his aspirations. In his search to learn more about public health, Mr. Pacheco was able to meet Dr. Christine Daly, who explained the great things the Center for American Indian Community Health, or known as CACH, has accomplished and how they use community-based participatory research to involve community members in all aspects of research. He was able to shadow a few of Dr. Daly's staff members for a week and get hands-on experience on the day-to-day task at CACH. Mr. Pacheco applied for and was awarded the Susan G. Komen for the Cure Fellowship, which gave him the opportunity to join Dr. Daly's team. Mr. Pacheco has also been able to mentor a new cohort of Native MPH students at KUMC. He's currently pursuing a PhD in health policy and management here at University of Kansas Medical Center, and currently serves as program manager for a web-based smoking cessation study based on All Nations Breath of Life. under the guidance of Dr. Juan Choi and Dr. Christine Daly. Next, Dr. Mugar Gianna is an associate professor of strategic communication at the William Allen White School of Journalism and Mass Communications. And I have to say that he was the cohort before me at another university in Columbia, Missouri. He's also the director of the Center for Excellence in Health Communication to Underserved Populations and director of the Health Communication Research Shared Resource for the KU Cancer Center. Dr. Gianna founded the Experimental Research Media Laboratory at the School of Journalism and Mass Communications, a major research resource for our graduate program. Dr. Gianna is a member of the Diversity Inclusion Action Group at the KU School of Journalism and Mass Communications, and has conducted extensive research on underserved populations and health. Dr. Gianna is co-inventor of, am I pronouncing this, is it Triple E? Triple E, triple, a platform of the delivery of personally tailored health news and information. Dr. Gianna teaches strategic communication campaigns at undergraduate level and research theory and methods at the graduate level. He's a recipient of the prestigious 2011 Basket Moss National Research Award from the Association for Education, Journalism, and Mass Communication, as well as other local and regional awards and citations. So after that lengthy introduction, we're, again, I don't want to speak for both of you, but as the planning for this symposium, we're going through the planning of this, I just thought, there's so many things that can be said. I wasn't able to make the first part of today's symposium, but I did hear, as I was walking in, a question about the social determinants of health. I think I heard that. And so what we're going to discuss, this is going to be a non-traditional panel. And so we're going to welcome your questions as we are going along. I do have some pre-planned questions, but we want to welcome you in this conversation. So that's what we're looking at, this is a conversation. So the first question I have under that a role of health literacy and addressing health disparities research, the first question is, what are the experiences, your experiences with working with vulnerable and diverse populations in the context of health literacy? And do you think that current research practices are addressing pressing health literacy issues among these populations? So I don't know if either one of you want to start.
Okay, so I've been fortunate to work at KH under Dr. Daly, and I've been able to be involved in a lot of different processes of developing like health literacy scales. So one of them is a tobacco health literacy scale where was just made specifically for Native Americans, and that was funded through an NCI R21. And so the long form is 25 questions and the short form is 12 questions, and we plan to validate that with other communities too. And then we also had the opportunity of working on a breast cancer health literacy scale. And that was ran by an NPH student that has graduated and moved on, and we were able to help her develop the questions for that scale and have it validated for her project. We've also developed a bunch of material, like cancer brochures. We have a series right now that currently has colorectal cancer and breast cancer, and within those materials that we ran them through different readability tests, so like the FRI and the SMOG, which is the simple measure of gobbledygook, and those both look at different levels of readability. So the FRI looks at sentence length, where the SMOG looks at the length of the word. And so we try to shoot for fifth grade reading level, but we usually land with different health topics around 7th and 8th, because when you have long words like diabetes, those are polysyllabic. There's a lot of syllables in there. It makes it harder for people to understand. And those are certain words that you can't shorten down to something different. So if you talk about cardiovascular, you can just say heart. But certain words like diabetes is a little challenging. We've also did the TOEFL among Native Americans, and we had about 500 participants. And surprisingly, within that population that did our survey, they had a very high literacy levels. But that goes back to there being maybe a bias in our sampling size, because it was a convenient sample. And the people that select to go into a survey or a study might have more knowledge about health than someone that didn't elect to go into that kind of a survey. So that's kind of the experience that I've had. And like we're doing a lot more at the center. Dr. Daly has other things planned. We currently have an R21 submitted for a home health literacy scale. And there's a big disparity. I'll get it if you guys want to get into later about that, about just home health and basic things, how that can make people sick. And a lot of our illnesses can't be caused at home. Like say if you have a kid that has asthma, are they having attacks at home, or are they having attacks outside of the home when their inhaler?
Well, it's rather hard to make a segue to that presentation. I'm not a health literacy researcher. I'm an interventionist and I'm a health communicator. So my encounter with health literacy issues came mostly from trying to do interventions at different levels, and also as the director of the Center for Excellence in Health Communication to Underserved Population, we do work with a lot of underserved groups around Kansas and sometimes in Missouri as well. So one of the things we actually found is, and I'm just gonna echo Dr. Haddon here, is that a lot of time we're trying to put the burden of health literacy on the patient. And that's exactly what my experience is. And I'm trying to figure out the best distance to be from this microphone. As very often, most of the intervention we're trying to do as we're trying to get people to take better care of their health or change their behaviors related to health is they need to understand the things that we're trying to tell them. We're trying to model our message so that will be understandable by our audience. And very often when it comes to underserved populations, either they're minorities, so we need to put a cultural change into our message, or we need to translate this into Spanish because they're Latinos. Very often as we're doing this, we're forgetting that a very important part of how we're engaging our population in terms of health resides with the provider. And this is one of the things that we've been encountering again and again, that providers are not prepared to deal with patients with low health literacy. And one of the things that I hope it will come in your presentation this afternoon, Dr. Haddon, is the fact that, yes, it's excellent. It's a very good idea to train our providers on how to deal with low health literacy people. But one of the questions is, when will they have the time to do it? Because time constraints, and at least in my experience, we're actually doing a pretty extensive research right now with cancer clinical trials. We found out that providers don't have the training on how to talk to patients about cancer clinical trials, and they don't have really the time to talk to patients about cancer clinical trials. And also another thing that I wanted to say, and maybe this is a discussion for later, is that I think health literacy to a certain extent is a contextual issue. And it was very interesting, the story that Dr. Haddon told about her grandfather, and the skills that elderly people need these days to be able to navigate. But let me give you another example, and this is a personal one. So I have an MD from the University of Medicine and Pharmacy in Bucharest. And I've been a practicing physician for almost 15 years before moving to the United States. And so I consider myself to have pretty good health literacy skills. Now, everything was fine until I had to deal for the first time with insurance, with health insurance. So here you have a highly educated person who has a medical degree, who actually, at least to a certain extent, is able to understand medical terms, okay? And then has to deal with a system that he's never been exposed before. And I think this is a situation with a lot of immigrants are facing these days here in the United States. And I agree, the system here is so different than systems in Europe. So from that perspective, I was completely illiterate, okay? Yes, I did have the skills in order to try to educate myself. I'm still working on that, to be honest, yeah. But that's why I said, I think health literacy, we need to look at it in terms of the context that is applied. And I think I'll stop there because maybe there are some questions.
No, but I think that is right on point and underscores what I've experienced as a researcher. You know, the approach I take is community-based participatory research, and with working with some of the African American population, specifically faith-based populations, when we are engaged in research, many times the issue comes up where that doctor-patient communication, there are a lot of barriers, and there's different interpretations where the doctor will say something and they don't understand, but because of fear, for various reasons, they don't want to ask. And so those are some of the unfortunate exchanges that can really impact the patient's health outcome. Any questions, though, from the audience as we are talking about some of this? I see Dr. McGee.
We're getting ready to say Dr. McGee, but let me tell you, I had the same experience when it was time for me to choose my insurance this last time. And then after I got it figured out and all that good stuff, I figured out at the end that that's not really what I wanted because I didn't understand it. So I'm thinking, if I don't get it, how do other people feel when they're trying to choose their insurance? And my father just had surgery here yesterday. But the good thing about it is this, he is so, I would say, more involved in his health now that he's able to tell the physician the procedure that he's getting ready to have. So the doctor came in and said, what are we doing today? And the way my father was able to articulate what was getting ready to happen to him was amazing. And that's because he's becoming more and more involved in his care. But it is how he's being treated and how the physicians and the nurses are communicating with him and talking with him and making sure that he knows what's happening with him. And plus he gets a phone call from me every evening to say you better be paying attention tomorrow. But I just wanted to piggyback off what you said with the health insurance, because I had no idea what I was doing, and then it's still not what I want, you know, even at the end. And then, but my dad is, with how things are changing and how we're talking with our patients, it is definitely helping. And so I hope that we continue that process.
Absolutely. Oh, I don't know who was first.
I think they're
Good morning.
Morning.
Christina Pacheco. So in my work, I'm based at St. Luke's Health System. We see a big push to engage patients in shared decision making. And so my question is, without some kind of baseline understanding of what their current health literacy levels are, how can we truly expect patients to actively be empowered in that shared decision making process? So that's one kind of question that I have, and I know that's not entirely related to what you guys were talking about, but that is something that I hope to gain some insight on here. And then also I think Joe brought up a good point about the selection bias. I think in a lot of the research that we do around health literacy, I think selection bias is an important thing to look at because, you know, our participants are likely to be more health literate than not, because they're willing to actually engage in that type of research. So it's also something to think about when we're trying to measure health literacy of a population. Thank you.
So I'll take a stab at the first part of your question. So like to assess like a patient's literacy level, I think that's kind of shows the need of different literacy scales for different populations. So the understanding like what is someone's knowledge about like tobacco literacy, what is someone's knowledge about diabetes, but then it goes into like is like the scale that we make generalizable to all populations, or is it only the population that we study? So I think as research continues in this field, we'll be able to answer that question a little better, at least with my experience. I don't know, Luger or Crystal might have a little more insight on that part. But like your second question, where like the selection bias, that is something I think with any research that anyone does, like there's always like someone's like have a threat to validity, like how valid is your study is going to happen on, like, you know, if I conduct a study and I try to make it as large as possible and have a large N, well, that might only be generalizable to that one group that particular year that I did my study, or, you know, if it's longitudinal, things change. Like there maybe there's a big event, and so that is a challenge with just doing any studies. And we had to kind of go with what we can as researchers and make the best decisions on how we can assess literacy, how we can make these different scales as we move on with our research.
I think Dr. Haddon has a comment or a question. So.
Yes, I was just going to say, I think that it's an awareness issue until researchers, until NIH really recognizes that we need to study our decliners. I submitted a research grant where we really wanted to, so we knew that patients with low health literacy were going to decline in the study. Those were the people we needed to get information from. And so we designed a study that was embedded within another trial so that we could access the claimants and get information from them. I haven't done it, but I think that's the way that researchers need to start thinking in terms of hearing the voices we need to listen to are the hardest to hear. We have to work harder to reach the whole population. We need to include in our study program.
No, absolutely. Because often, again, going back to your point, it's those very voices that are not represented. How can we, if we don't, there's no opportunity to do that. Question or comment on the same?
Another question.
Oh, okay. Well, let's.
Yeah, I think that.
We'll come back to you. We just want to kind of give an opportunity for if anyone else has a comment on this issue that we're
I just want to
now.
I just want to make a very quick comment here on what Christina just said. We did a study and we actually recorded patient-provider interactions to try to understand, and this was all about talking about cancer clinical trials. And we wanted to understand how providers communicate to patients. And let me tell you, health literacy was definitely not on top of the mind of the providers, because as we are analyzing our records, we found out that they basically, and there were different providers more or less telling the same things to the patient, no matter what the education level or actually the understanding level of the patient was. They had a skill to do, and they were doing it. So I totally agree that education at that level needs to be done in order for the patient to be able to tailor the way they communicate, for the provider to be able to tailor the way they communicate with their patient.
I think there was another question or comment in the back. I apologize. Forgive me.
Guys,
you're right there. You're standing right
Please
there.
don't fight.
So, forgive me.
I work in the hospital, and I'm the hospital standards coordinator, and I work on our Cranes education system that we use that's system-wide, and help with people that are doing custom builds. I'm pretty self-taught. My background's in pediatrics, so I always thought that I did a pretty good job teaching kids, families, etc. Your comments related to the provider and the time and simplifying things is something that I was fortunate in pediatrics that I think we did offer that opportunity to give families a little bit more, so we have the kid and then we're talking to the families. When I help do custom builds for folks, the barriers to that's not how I want to say it, when in essence is the same statement, however simplified. And there's some really great examples out there, but I have a really hard time. I worked at the Cancer Center not very long ago, and it was written on a college grad level. And when I give them those tools of saying, I'm not going to spend 90 hours working on renovating and redoing your education, when you don't want to hear it, that it's too high, and the patient doesn't care that it was established in 1977. Somebody told them they had to come here to have cancer. Start with the basics. So and it was all ages. The providers that I was working with were newbies to very experienced providers, and my struggle with is as a really a tool to help people develop education was how to get, and it is predominantly providers. I find that my nurses that I work with are much more, oh, that makes more sense. But the providers are like, well, you took away the
understand, what I wanted to say. But in essence, it really didn't. And my nurses would say, no, that I understand that. So I need tools. I'm struggling with tools to talk to my providers to say, giving them a list of medications that they have to have a prescriptions for in their discharge education when they walk into a pharmacy. They're not going to ask the pharmacist, what do I need? Because the pharmacist is going to say, well, you need prescriptions for these. So why are we including information on that? I had a provider call me and tell me I dumbed it down so much that it made the hospital look stupid. And so, those are the kinds of things that I need tools to say, without having someone that's health illiterate sitting there and going, I don't understand this, please help me. And we oftentimes I hear the provider go, I just don't have time, but they don't really, there's really not a desire to give the time to learn. So I struggle with that, and I always wanted to know better tools to use to help the provider understand what my goal is to make it as understandable and readable as possible.
If I may add, not that we need to pile on the providers right now, but I think they're right too, because they have so many responsibilities. They have really a limited time in which they need to do their job, and they're striving for them to do the best job they are able to do. So I completely agree with you. Tools are needed. The way we can actually simplify how we're training providers are needed. And we need to be very conscious. And we found out, like I said, my research right now focuses a lot on trying to increase accrual to cancer clinical trials. And we found out that, not only providing them with simplified tools, but provide them with the aids that will facilitate that discussion with their patients is extremely important. Okay, so not only telling them, hey, you need to tell this, this, and this about the patient, but hey, here's a table tent with all the information that the patient needs. Okay, here is a flyer or that the patient needs to get before coming to see the provider. Okay, or here are some online resources that are available for the patients that will answer many of the questions that the provider will get. So we're getting a more informed patient in front of the provider, which means that we're actually prioritizing their time and we're making the whole provider-patient encounter more efficient. We're developing some of those tools.
I think also what you, and so I don't want to, let me ask you, you are facing, it seems like, just finding those actual tools that could be beneficial to not you, but also the physicians. I don't know that, but I do see I'm not trying to put you on the spot, I do see a provider here within the Department of Family Medicine. Is that something that you know about, or just wanted to ask? You had a question also.
I have a question also. It's really a side comment. I think that the way that we do that is not very efficient. And it has to do with having psychologists go in and observe providers and then offer them feedback on the way they're communicating with their patient or what they may not have noticed. There's a whole nother context that I think we don't always think about. I too am concerned with calling this health literacy and placing the blame for it or the responsibility for it on the patient. Because sometimes I think if you don't have an advanced degree in something, you couldn't possibly understand that. But the other context I'm concerned about is illness. So right now I'm running a group coping with chronic illness. And a lot of times the patients come in and they feel blamed for getting things wrong or for not understanding properly. And all of the patients in my group have good health literacy. And also sometimes their care is very complex and it's difficult. And also sometimes they're very sick. And if you're not giving someone a lot of important communication when they're very sick is like, why bother? I don't know, I think it's another kind of nuance when you're working with patients. You have to keep in mind how their wellness or lack thereof affects their ability to understand what you're saying.
I thought there was another.
Am I up?
Yes, you are.
All right. Here we go.
Yeah, here we go. So you mentioned about tools to help. I know that there is the Universal Precautions Toolkit that's available through UNC, which teaches, as you mentioned before, keeping things very basic for everyone, using teach back, slowing down. I mean, there's research that shows I think if you slow down your intervention by a minute, you can see improved outcomes by about 17%. So it's not a whole lot of time. But I guess my question for you is, we're making a huge deal about health literacy, but also about how we communicate with our patients, right? So what sort of work is done here on campus with our med students, our nursing students, or School of Health Profession students in terms of patient-centered communication, patient-centered care, as opposed to the more paternalistic model that most of us have grown up with?
I'm at the Lawrence campus all the time.
Well, my teaching is primarily with provisionally medical students that have been provisionally accepted into the school. But I will say this, in the course, it's this social determinants of health, implications of primary care. And one of the components of the course is looking at health communication as a social determinant, and allowing them to see how communication, as far as between certain populations that are from different backgrounds, can see different health issues very differently. In fact, I will just draw from experience. This is through data collection, not from this course, but with some focus groups that I just held a few weeks ago on this whole genetic, communication. I know that's a different thing, but in one of the faith-based organizations, some of the individuals, before we could even talk about the genetic communication, they essentially said that, if I see a provider, first of all, I don't trust them. I mean, it is what it is. And they said, as far as their communication or the doctor's communication to them about certain issues, it is really difficult for them if they say, okay, well, you need to do X, Y, and Z. Well, first of all, I'm trying to think about how my lights are going to be turned off. I'm trying to think about when my not the next meal, but essentially how I'm going to get certain things. And so I don't know if that answers your questions as far as, and some other people, if you could please jump in here, as far as preparing future physicians for that health communication or that exchange of a communication. It is something that is, for me, it's a process. It's a process. So, yeah.
I'm a librarian. I work with a school of nursing. Hi, I'm Brenda Linares. I'm one of the librarians here. I work with the School of Nursing, and they have a health communication class. And I've been very fortunate that last fall, I actually, there were two faculty teaching the class, and they invited me to teach in the class. And they were concerned about basically them understanding about, how to read an article, but they were also concerned about a lot of nurses tend to speak with the family members because they're the ones that go and explain things to them and have a lot of communication with that. And so as part of that class, I was able to do several sessions. I think I did 4 sessions about understanding how to talk to them, what level they need to understand the health topics, what resources are available for them, like consumer health resources like Medline Plus, which some of you know about. Understanding that so that when they talk to them, how do they talk to the patient? How do they talk to the family member so they can understand the health issue that they're dealing with? And so it's been a really good experience doing that because they're trying to understand things from the patient and the family perspective, because they already know that they're dealing with it as the nurses are dealing with it, but then getting that perspective, it helps them because we had some scenarios that they were, that we showed and saying, well, how can you explain this to that person if they don't understand what's going on? And so that has been a good experience for them.
And I'll just piggyback off. So thank you for reminding me of that. That's within the Department of Public Health, Prevention of Public Health. And now what I understand is that that health communication course, I'm not sure how many medical students go through that, but I'm thinking that that is something that needs to be implemented, that we have the cultural competency course or not as part of a component for medical students, but definitely, so thank you for bringing that up. Was there another comment?
Yeah, thank you, Brenda, for speaking on behalf of the School of Nursing. I would just add to that patient-centered care as well as patient education is the core of what the School of Nursing does, and it is threaded throughout our education undergraduate program all the way through our advanced practice nurses. So it's something that's threaded. However, I do think there's opportunity for improvement in all programs.
And on the Lawrence campus, we conducted a workshop last year with students from pharmacy to try to teach them how to communicate to lay audiences. So we're trying to address the other component of care, which are the pharmacists.
I want to go back to a statement that Joseph said about different measures for different populations. I work with Latinos. That's my focus of research in nutrition literacy. And then we have documents in Spanish. We work on development of an instrument that was culturally adapted in Spanish as well. However, we have figured, seeing during the research, that only translated to Spanish sometimes is not enough. Because even in Spanish, we need to work with the health literacy on other languages as well. And then most of the research, I agree with you, we need to have different measures, but how to compare across different populations, because the system that we are working here in the US is the same. And sometimes I question myself about not creating a bigger stigma in a population that sometimes is already stigmatized. So as working with another minority as well, who also has a stigma, how do you see it? Because at the same time, minorities are not highly included in research. It's hard to get them involved in research. Sometimes the ones that we have involved is high literacy levels. So how do you see that? Because I have my questions about it on if we had to simplify even more than what we have right now.
Great question. So at the center, at CAGE, we use the CBPR method, so community-based participatory research method, and that is mandated if we want to work with tribes because of the hurt that researchers have done to them. And so in our community, we're really involved. So do you know what CBPR is? Yeah, so really involving the community and finding out what the need is. And the way you try to avoid, I think, stigmas is how you report your results. You don't make it a negative connotation. So if you go in and look at some of the research that's been done in the Native community, where it's very disparaging on how the news outlet will take a research article and then spin it to say, oh, well, look how bad this population is. And I think that is the challenge with any research is that you don't want a news outlet or a media to take what you put out there and spin it to where it's oh, look how bad this population is. This population has zero health literacy or whatever it be. But that's not the case, right? The case is that with all populations, there's going to be some groups in that population with high literacy and then others with lower literacy and then in between. But like mentioned by Dr. Haddon, trying to get the decliners to understand what the actual level of that is. And then when you talk about culture, it's how do we define culture, right? It's the culture is not necessarily based off of race. It's based off of maybe the community that we live in or the people that the language we speak. So that is another challenge when developing an instrument. So it takes that community approach to really understand the culture and to get in there and understand the needs of the community that you're highlighting. And that is the challenge with research because you can, like I mentioned before, you work with one community, then that instrument might only be good for that community that you're working in, and then trying to make it as generalizable as possible is, I guess, what our main goal is at the end is, okay, so we validated this community, now what are the steps we can take to move it to an even larger community? And we've tried to do that with one of our quit smoking programs, All Nations Breath of Life, where, there's different aspects in different Native communities where, for instance, using traditional tobacco is not used among every group, every tribe, but incorporating that into our program is important for those. And so trying to understand what's important for one tribe and other tribes and kind of bringing all of them together so to have a successful program. Dr. Daly and Dr. Choi were successful at doing that with All Nations Breath of Life, which is a group-based quit smoking program. And now we're trying to take that into other programs. And like Jason here is working on a quit smokeless tobacco program, so All Nations Snuff Out Smokeless, and trying to do the same thing where, you know, like you take these materials and you make sure that they're readable. Make sure, like I think someone mentioned about graphics, you know, you run them through the suitability measurement assessment, SAM, and seeing like, okay, like I have pictures here, I have a graphic here, like how is my page readable based off of that, not just off of like word length and sentence length. So it is a challenge, and I think just trying to get out there and like you have your main goal as a researcher, and you know you work with the community and figure out how you can reach a larger community. I think it's a challenge for all of us. Does that answer your question?
And I understand what you're saying about having the community engaged and having their perspective, but at the same time, I don't see a lot of effort about the system adapting to the population, you know, and this is the population that we see most in the hospital because, for example, I work with nutrition. When we see diabetes levels, it's so high among African Americans and also among Latinos as well. But I don't see at the same time adaptations to integrate this population in the care. So sometimes, I'll give you an example. The documents are simply translated to Spanish, not adapted for, and now coming with my nutrition background, right? But what people actually eat. So there are several things that as a dietitian I will come and explain. They have never tried that food before. So how effective is that just translating to another language or?
So it's all about tailored communication, you know, and I'm going to echo what Joe just said here because it's extremely important to really work with communities. Now I work with Latinos, I work with American Indians as well. You know, getting the cultural right, the cultural component right, and it's not only about language. Unfortunately, I agree with you. That's the first thing that comes in mind when people say, hey, we're going to adapt this instrument or we're going to adapt this material for this audience. I'm just going to translate it into Spanish. That's it. But it's not. And, you know, if you look at Latino communities, so if you have Puerto Ricans, you have Mexicans, you have Cubans, you have a multitude of tribes on this other end, you need to work with populations that are representative for the sample. They're representative for who you want to study. And you need to tailor all your instruments and all your communication efforts to those particulars.
But I also hear, and correct me if I'm wrong, I also hear a systematic issue barrier. And then, so piggybacking off of what you said about the tailoring and those skills being very specific to those populations, showing the evidence and presenting that evidence to those decision makers in that system and showing them why integrating that into the system will be very beneficial. You know, showing as far as how it is now, and then after those more tailored skills are applied. In my mind, that's where it's going to have to be. It's integrating that into the system and showing the evidence.
Can I piggyback off of that?
Yes.
Systems and information from Arkansas. So some things that we're doing. First, I want to share a huge mistake that I made early in my career when they forced me to go on a morning show on Health Literacy Month, and I hated it. And I was so focused on the message that health literacy is important that you know what those Arkansans walked away with. Oh, those poor people with low health literacy. I mean, the messaging was just all wrong. And so I think it's important that as we talk to decision makers, the narrative is important. When you talk to decision makers, yes, it's important, but we're not blaming anyone here. We're saying we need to do better. And so if you demonstrate things like, one thing that we did is we were given something to translate into Spanish, and we are very fortunate because we have a Spanish health literacy specialist at our center. She took this document and she said, it was on depression. So this document says that you are literally, your skin is going to be turned blue and you're going to be on the floor because it said that you may feel blue or down. And the translation was just all wrong. And she so I said, I want you to share that with someone. So we start sharing these stories with the decision makers who can make the systems changes and provide the resources for us to do it the right way. So I think those stories need to filter all the way up to the top. And careful what you say on the news.
Let's go ahead.
I have a question. It's actually also like Juliana's comment, a question based off of a comment that Dr. Gianna made a bit ago. It's about how do we address the different frameworks that come into play when they deal with this new health system regarding immigrant population. As I have experience with bicultural health system. I'm a visiting medical student, and I'm working with the Latino population. And a lot of the comments that I hear from Latinos are based on, you know, that kids game where it has different shapes, and they're really struggling to put the star in the circle. Yeah. They're coming in with their circle, and we're giving them the square.
Yeah.
So those conversations are being had, and they're, like you said, we're talking about insurance when they have severe abdominal pain.
Right.
And then it just sends the message of, I know you have an issue, but give me a second. Can I even treat you? When they're feeling foreign as it is, it's a very inconvenient time to have a discussion. So I'm wondering, how can we address this even before they have that issue? Even before they get into a new healthcare system and introduce it as this is going to be different. This is what to expect. Because now they're coming into a circle frame with a circle. And there's still going to be some mishaps, right? But there's a little wiggle room for us to really address that.
Well, that's a tough question, actually, and a very important one. You know, health communicators, we always like to say how important health communication is and how important it is to get your health information. Just out of curiosity, how many of you have looked at any health information today? Okay, that's more than the average that I get usually. Because there's one reality that very often researchers don't want to accept, you know, or health communicators, is that we are looking for health information when we have a problem. Or we're looking for health information when somebody in our family or friends, we know they have a health problem. I mean, how many of you look at political news this morning? Come on, really? With the Mueller report and everything? Okay. So that's the reality. Health information becomes important to us the moment we have a problem. Okay, we are not regular consumers of health information, and because of that, we have seen all these challenges in terms of educative, of communicating. But we need to change this, and I'm just gonna talk a little bit about the research that Crystal and I did with a colleague of ours in Juncel. And you know, we were talking about health information and how we need to adapt all that information, but we also were talking about a specific population, like for example, the elderly. We're talking about them needing to search for health information. And guess what? What is the main source for health information these days? It's on the internet, right? So we can actually separate health literacy from digital literacy, because that's a really big issue. We have populations that are not able to access, they want to access health information, and they can't because they don't have the digital skills to do it. So all these things, that's why I keep saying that I think health literacy also needs to be looked into context, because all these things matter as we're trying to communicate, as we're trying to address different things. Yes, there's a question.
Oh, and Dr. Levy, she's first, and then.
So I wanted to address the comments that were just made by this young lady and the other young lady, because I think that I think we have to be more responsible, more patient-centered care, because one of the things that we teach our students is that when you teach about diabetes and the foods, the things that they need to change, when you're talking to an African American, someone in African American community, or someone from the Latinx community, you have to say, instead of cooking your greens with fatback, you need to use smoked turkey. You need to use, there's different things, there's different approaches to how we can cook our foods and how we can address these individuals. And I think that we have to be responsible with the questions and what's still happening today in 2019. This is not okay. Right. We know better. We should be doing better. And it goes back to cultural competency, patient-centered care, and patient education. We know better than this. We've been teaching about this for a very long time. We have to do better. As a community, we have to do better. We sit right here in Wyandotte County at this university, and we are surrounded by Latinos, African Americans, and a large Asian population. And I hate to say it, but there's no excuse. We have to be responsible individually to learn more, to do more, and to have a different approach to our patients, to individuals, families, and big communities. We can talk about getting on the internet, and we need to get on the internet so that we can learn it. We need to talk to families so that we can approach individuals differently and better, so that we are feeding them the right information, and so that we look better as KUNC sitting right here, so that we look better, so that we don't have those questions, so that we can stand up and say, you know what, so-and-so is doing better. This community is doing better because we're doing the work. There's a lot of really good research going on, and I appreciate everything that everyone is doing, but I'm a practitioner. I have a doctorate in leadership. I am a practitioner of leadership. I don't have the research degree that you guys have, but I definitely I implement everything that you do. But we have to use that research to do better instead of continuing to have these same conversations over and over. We've been teaching about cultural competency. Now it's time to put it into practice.
Good. Okay.
I have to go to the
I'd like to jump in on kind of what she said and what other people still have like some questions. So like we have to do better, right? But who's been to a doctor in a major hospital? Has anyone looked at the health information that's in that lobby? What's the health information? It's how great the hospital is, right? So like hospitals and the health system. So we can talk about providers need to tell their patients this and this, but I make a great brochure. We test it in our community. They love it. Who's going to see that brochure? Not the people that come to the hospital. Not like I had to go find the places that I can disseminate that at, and the people that are going to go to those places might not think about, oh, I'm going to go to my tribal clinic to pick up something about colorectal cancer, where I'm at a specialty doctor at a hospital. Then so they might have stuff about colon cancer in specialty clinics, but that's a huge issue. And in other communities too, in our community, that continuity of care doesn't exist. So you build a relationship with a doctor if you have that privilege, and hopefully your health literacy won't be that much of an issue. But when you don't have continuity of care and you see a different doctor each time, like a lot of our military, when they go to TRICARE, they just don't have that continuity of care. And the other issue that we talked about being better, we saw that clip of House, and there's a lot of chuckles. Did that disturb anybody that the room laughed? That's a serious issue, right? So you think of that, someone gets told to take Tylenol until their pain goes away. Okay, well, I'm going to keep taking Tylenol, but I don't quite understand to read the back of the Tylenol bottle, where I'm only supposed to take so many every hour, not so many every 24 hours. And then next thing you know, I have liver toxicity and I die. That happened to a friend of ours. They went to the doctor. He couldn't afford to go. He didn't have insurance, so he went to a minute clinic. He was told to take Tylenol. And then one didn't do it, so he took two. I'm still in pain. And then that outcome comes out, like the inhaler. Luckily, she didn't have a major asthmatic attack. And then we talk about culture too. Like, if anyone's read The Spirit Catches You and We All Fall Down, that shows a great way of like how doctors don't understand other cultures. And it's a lot to ask a provider to understand every culture that comes in through that door. And so I think hospital systems need to try to figure out like what populations they have. So like there's a large Somali population here. Like I don't know if there is like people that are giving cultural talks to doctors or having sessions of You know, like what are the beliefs of the Somali population? What are certain ways that they see certain treatments? You know, like if you're Muslim and you have to get like a device to treat cancer that's outside your body, how's that going to affect their prayer? You know, because they have to be clean. That's the part of their belief. And if they have something that makes them seem dirty, they can't pray. You know, it's all these things that it's a very complicated issue when we go into just, you know, being responsible and understanding the culture and how to educate the different populations on like their health and like how they can navigate a system. You know, like even with Medicare, you know, the older population, like people don't even know how to fill out the forms. And you go to fill out the form like my dad did, like he doesn't understand what he's electing. He doesn't understand the form at all. And so now you got to worry about like the form literacy, and that's, you know, through the federal government. And do they care? I hope so. You know, like they try to give this care to a population, but they don't care if you can fill out a form, and the person at the desk can't help you, because that's not really part of their job. You know the information, you fill out your form. And so that's just kind of what I wanted to say to touch on some of the things that we talked about. No, I think we're running out of time on our talk.
We have a few more minutes, but I know that, was there someone over here that had their hand up? Oh, I'm sorry.
So I know this has been said a couple different times, but I think the focus really needs to be on decolonizing systems, particularly health systems, as well as policies. And we as researchers, I know there's probably a lot of researchers in the room, we have a strong focus on evidence-based practice. NIH really pushes evidence-based practice, but I think some of the nuggets of health really reside in practice-based evidence. There are tribal clinics in reservations that are really doing some very innovative work, and it's working, and you can point to that. And when you decolonize systems and use practice-based evidence as the evidence supporting that, I think that's when you start to see the change that you're looking for. Community clinics have been doing this for ages. They don't have the quote-unquote evidence base to do it, but they have the practice base to show that it works. And so really as researchers, we need to start partnering with those clinics and those tribal clinics to really show that the evidence exists and that, you know, communication can happen on a level that patients and community members understand, that providers can be trained to have those communications that start to make the changes in these communities. And I think until we do that, we're going to continue having these discussions and need to have these forums to talk about these things, because nothing's going to change until we start to change it.
And if I may add, that's a really great observation, Christina. We need to stop thinking as the only interaction that a patient and a provider have is during that encounter. Okay, we need to think and start acknowledging that there are things that happen outside of those 10 minutes or 20 minutes that the provider is face-to-face to the patient, okay, because that's limited time, okay. There are tools that we can design and there are interventions that we can develop that either extend the benefit of those 20 minutes of provider-patient interaction or prepare the patient for those 20 minutes of provider-patient interaction. I'll give you an example. We're developing right now with the Department of Nutrition a series of videos addressing how to use nutrition to address some of the symptoms of cancer therapy. And they are all patient-tailored, okay? And there are a series of videos that actually help the patient either before or after the encounter with the doctor to try to better understand why they need to do this X and Y or Z. And I mean, we tested some of the videos and there's a phenomenal result. And we can do that, okay? So maybe one of the things that we can take out of this meeting today is the fact that, yes, when it comes to health literacy, there are a lot of issues that we need to address, okay? But I think there are a lot of opportunities as well that we need to start thinking forward, both as practitioners and as researchers.
All right, Andy, I thought there was one more question.
I agree. I was thinking as we were talking, I love that analogy about having a square and finding a circle and thinking, what? But then I thought about that from the provider view. You've got your circle, but you have no idea what shape that other person is coming in with. It is a total mystery, and you may not even figure it out by the end of your 15 minutes. And this idea of using the system as a translation device, a way to, before or after, help the provider figure out what shape is walking in the door, and maybe the patient figure out what shape is waiting for them. I had this little imagining of a video, like we were talking about resources. It just so happens that the Mayo Clinic has really good patient resources available, and I refer patients to them all the time. But won't work with very low health literacy. Some of our patients don't even have written language. Some of our immigrant patients come from cultures that do not have written language. So I still don't know how to figure that one out. But if we had a video, what if one of these cancer docs had their spiel for what they want to say about cancer, and the patient listened and just pressed a button every time they did not understand something? And what if there were little things, like if I'm on Wikipedia and it has an underlined word and I don't know what that word is, I can click on it and it tells me. So what if we had a spiel and you could just have a pullout of anything you don't understand? Or the doctor got the results of your clicks, like, wow, they understood 15% of what you said. Maybe this is a problem, how can we fix it?
We can do that.
I'm in.
Let's talk.
Another question.
I'm going to piggyback on something you said that also I thought of during your presentation when you had the 30 deliverables of health literacy. And you said that you guys narrowed it down to 8, but what is it? Competencies. Thank you. And I just had a thought about all the healthcare providers. And I've had this thought before, and I need you guys to help me, because I have a master's in teaching, and I taught English for 25 years, and I train teachers to teach. And even training teachers to teach can be a challenge. So we have all these doctors and nurses and OT and PT, and we expect them to teach not just our students, but also the patients. What training are they getting simply to teach? How are we training all these people to be teachers? I wonder.
Yeah, that is a very good question. My understanding, I'm not a physician, I'm a social scientist, but what I hear from, my colleagues in the department, or what I see also is, the students, they're getting trained to treat the patient, but many times I think they're in the cultural competency class, but that's just only the beginning. And like you said, that's a great point about actually teaching, because in teaching, there's more than just giving information, right? There's checking for understanding, and so that's a great question.
I did research with chronic pain patients, and if you want to talk about the group that has a social stigma, we can talk about that group definitely. It's interesting that during the entire medical school, students get approximately 2 hours on training on pain and chronic pain specifically. In the veterinary medicine program, they get 18 hours of training. So I just want to leave it at
Well, I don't know what our time is like. I think we have maybe a couple of minutes. We have a few minutes. I didn't mean to. I'm always overlooking everyone, so I'm forgive me.
I'm always full of questions and comments, so.
We welcome that.
So you mentioned about teaching training. Yes, there they are. So I know in our dietetics courses, at least at the internship level and the graduate level, we have no classes in terms of teaching, and that is precisely what dietitians do. They teach their patients about proper eating patterns for different chronic diseases. We do get some at the undergrad level. I know in my undergrad, we had an entire semester on counseling techniques, and yet even then, it's not nearly enough in order to be a competent educator? I know I've taken a couple of education classes here on campus, and even then, I'm still not sure if I am a competent educator, much less other students from other undergrad programs that maybe didn't focus on counseling. I'm a big proponent of increasing counseling experience in our field. Fingers crossed.
I'd like to share just some things that might be relevant from the research space and about training on these competencies. Cliff Coleman has done a lot of research, and his findings on if you put time and effort and strategy into training, he works mostly with medicine, so medical students. He has graduated cohorts of medical students who can demonstrate these competencies effectively through simulation, through interaction, through didactics, through all of these things. But then he said, it's so disappointing when he does this follow-up study, after they leave and do everyone's nodding their head, you know where I'm going with this.
Yeah.
They go to their residencies, they come back, and they have regret. And they're not demonstrating the competencies in practice, which is when they really need to be using them. And so he said, so far, the only thing that's been effective at bringing them back to their baseline when they left is peer policing. So if you say, resident A, you're in charge of resident B, and every time he or she uses jargon, you get to ding them. And it's peer monitoring has been effective, but we're still trying to figure out how to fix that. So he and another colleague of mine who works in medical humanities started exploring professional identity development, which is a different way. So you can teach skills, you can teach knowledge, you can teach. But if the real problem is with their professional identity, good luck. So what we're trying to do is when we get our first year medical students in a practice of medicine class, we start planting the seed that you want to be a good physician, you have to be a good communicator, period. If you're not a good physician, because what they come in with is, to be a good physician, I need to be a good scientist, which is by definition almost not a good communicator. Right, I'm not a good teacher, right? And so we're trying to tackle this. I mean, we don't have the answers yet, but it's these conversations that will get you there.
Thank you.
So Jason already gave us the minute warning probably about like 5 minutes ago, but so I'll be real quick. So when we talk about teaching too, another thing that we need to consider is different social determinants of health. You know, like how can we teach somebody and then tell them that they need to do this, send them home and they don't have the resources at their home. But another thing too about teaching and kind of what she just said is that I went to a rare case symposium and Dr. Ken Kimenow gave a great little demonstration about how PhDs and doctors, we spend a lot of time learning how to speak whale. So she showed a video of Nemo where there's Dory's talking to the whale, right? So we spend a long time learning how to talk like a whale, and then when we go out to talk to other people, we still want to talk like a whale. So that is something I think that is a challenge for all of us, not just MDs, but like PhDs as we write stuff and make things like accessible to the population, like, you know, so that way they can get knowledge about their health, you know. So we need to learn how to stop talking like whales and be able to talk like Dory or Marlin, so that way we can have a more sensible conversation with everybody.
I don't know if we have time for one last question. Do we? Probably not. Sure.
There's one in the back.
Oh, there's 3. I'm not sure where.
And after these questions, we will take a break.
Okay.
Okay, last 3 questions.
Okay, so a lot of attention to when people get into the health system and their ability to navigate it. Is there research out there on the avoidance for that very reason? Lots of reasons to avoid getting into the system and getting into healthcare, but is there research on how many people avoid for their inability to navigate easily? And secondly, delays in entering the system related to health literacy?
So there is some, like, just trying to even get to the hospital, like say for people with disabilities, that is a challenge where it might take them an hour just to get their socks on, then they don't have a car, and then, so that goes down into like more of the social determinants of health research on like looking at that, like how can we get people to even go to the doctor? Like what barriers are in place that are stopping them from getting there? So that is a line of research that is, I think, being conducted, but it's not as much as it should be. But I think it's something that is coming like more kind of like health literacy is becoming more in the spotlight, where like how we can get people to navigate and understand, okay, I need to go to the doctor for my mammogram because I'm at this age. I need to go to the doctor for colonoscopy because I'm at that age. And I need to, like, if I get a colonoscopy, I need to make sure I have a resource of getting a ride home. And, maybe trying to, as providers, maybe look at the research of maybe I can just do the at-home test, the FOBT test, and not have to actually get the colonoscopy. So I think it's one of those things where the research is still trying to tease out, kind of like with breast cancer, where the mastectomy is the gold standard. And then, the lumpectomy was found to be successful, but getting providers to try that is a challenge. So I think that's something that's going to come with time, hopefully. Fingers crossed.
And there are other issues as well. Okay. So not necessarily not knowing the system, and then you don't go there because you don't know the system, but you don't go there, for example, if you are an undocumented immigrant, you may avoid going to the doctor because you're afraid of the repercussions that will hold. Or you don't really know where to go, or you're the only provider for your family. So it doesn't matter if you're in pain, you're just gonna keep going because you have to provide for that family. So there's so many issues that we need to talk about them and we need to put forward.
Yeah, and I think that's the essence of my question, is that so many barriers to get people into the system. There's lots of them. Is there any research on people avoiding because we make it so hard for them to talk the talk, beyond the social determinants, but specifically about being able to, read their appointment time, read where they go, the parking lot, but their inability, but mostly their inability to talk and communicate with us is really kind of the essence of my question.
So I don't know about general health, but I can tell you that there's research out there that shows, especially when it comes to enrollment in cancer clinical trials, that people don't do it because the moment they're exposed to the consent form, and I don't know how many of you have read a consent form for a clinical trial, okay, they actually don't do it. They decide not to do it because they really don't understand what's going to happen to them. And also there are misconceptions, and I'm going to blame House for that, okay? I mean, yes, I know that's a great clip, but we're finding again and again that pop culture has done a really big disservice to the way especially advanced medical treatments are viewed. Because a lot of people will perceive clinical trials as being a last resort. Although most of the American Medical Association will recommend enrolling in a clinical trial as a treatment option at the beginning, especially when we're dealing with cancer. Because a lot of people have seen House or they've seen ER or something else, and there's nothing we can do. Let's enroll in a clinical trial. Okay, so that's the mentality that a lot of people, and again, yes, low health literacy too adds to that factor. They'll perceive that there's nothing else they can do, and I'm just going to be a guinea pig for research, and they actually decide not to enroll.
Dr. Haddon, I think she had her hand up, and then we're probably going to have to.
So to tease health literacy out of that avoidance, it's too complex. I think to tease it out to say it contributes this much to the problem, I'm thinking of I don't think there are any regression models that show, norms drove that avoidance this much, and fear drove it this much, and health literacy drove it, this coefficient. To my knowledge, that research is not out there. I think we need to do more in the space of trying to tease things out, but also acknowledging it's complex. It just is. And just like social determinants of health, you can't really separate one out from another. They're very tangled, and they all contribute to the problem. So we really have to figure out how to address all of them.
I just have a quick comment. I'm with the School of Nursing, but I'm fairly new. I got here in August. But my background is as an English professor for many, many years. So when we're talking about literacy, we're talking about language, we're talking about cultural. And words matter. So when we use the word competency next to culture, that's problematic. You know, it's a hierarchical phrasing. So I've heard this term cultural humility. And I would also like to add one comment at whether you are a teacher, a trainer, a clinician, a provider, a physician, a researcher, plug your term into this phrase. We use it at the end of yoga class where we wish each other namaste. And one translation of namaste is the teacher in me bows to the teacher in you.
I love it. Great. Well, on that note, so thank you for that comment. We will end our session and transition into the break. So thank you so much for this rich conversation today.
Thank you all.
Thank you, Dr. Lumpkin. Wonderful panel, wonderful, thank you. So yes, we will take a break. We have about 10 minutes to get a coffee, get some tea, and we'll set up for our next presentation.
So now there's no escape. You know you're gonna be saying this from now on. There's no escape.
Okay, so we're going to go ahead and begin our next session. Of course, as always, you know, help yourself to coffee and tea, leave as you need. I'm going to put another shout out to our Zoom participants. There may be some people joining us, some people leaving us throughout the day, so we're just grateful you're with us. And if you're on Zoom, please feel free to add a comment or a question. We're monitoring that on the chat box. If you want to personally ask a question, that will be allowed during the question session. So you can unmute yourself. Our tech will unmute you, and you can even speak to us personally if you'd like. So that was, the sessions so far today have been amazing. I have to say that, you know, I'm not a scientist, I'm not a researcher, I'm not a healthcare provider, and it's just so interesting to me, just as, I would say as a patient, as a mom, just incredibly interesting, and as an educator. So thank you for our speakers and for our audience and all the wonderful interaction. Your questions, your discussions is what's making this so rich. So our next speaker, and you can look up here and see we have an MD PhD with us, Dr. Kearns. She is an assistant professor here at the University of Kansas Medical Center, professor of medical ethics and palliative care. She practices palliative medicine and provides clinical ethics consultation at the University of Kansas Hospital. She teaches ethics at KU's medical school, and she does research at the intersection of history, policy, and ethics in the areas of end-of-life and health disparities. So let's please welcome Dr. Carla Kearns.
Good morning. Everybody hear me? Excellent. I will be looking for audience participation, so I'm hoping everybody's ready to help me solve the case of what we should do for this beautiful young, not so young lady. I have no conflicts. Okay, so this is a real patient who I cared for when I was a medicine resident in the resident internal medicine clinics. At the time that I met her, she was 63 years old. She'd had hypertension and diabetes for about 30 years. She was originally from somewhere in the Southeast. I can't tell you for sure, Mississippi, Alabama, somewhere like that. She had lived most of her adult life on Army bases all over the world, raised 4 kids, and lived in a dozen countries at least. She was referred to me by her twin daughters who were in their 30s. One of them came to me with symptoms of frank new diabetes. I had gotten A1C testing on her. I think she was about an 8, so just a little high. Our goal for someone with diabetes is less than 7. Normal is 4 to 6. So 8 is higher than you want to be, but not out of range. She had had symptoms. She knew there was a family history. She got her blood sugar tested at a CVS or someplace and came to our clinic saying, I think I have diabetes. She was right. We started her on diabetes medicine. We did some lab tests. We sent her to get her eyes checked out, all the sorts of things we would normally do for someone with new diabetes to get her sugar under control now and keep her healthy going forward. Within a few months of that, her sister just checked her sugar just out of curiosity with her glucometer and found that she too had elevated blood sugars. They are of course twins, both in their early 30s, both a little bit heavy, and so this wasn't surprising. She brought her sister to me. We got her set up with all the care that she needed. And what my practice for really to learn more about the patient, to find out what their family history is. That helps me a lot with what can we expect, what complications are we worried about, are there reasons to be worried about particular complications happening earlier in this patient or family than others, and what should we be thinking about in terms of their values and goals and hopes. If their parent or their uncle or cousin had developed blindness, heart attacks, nerve damage at an early age, that's both informative to me as a physician and highly motivating to the patient. My goal for you is to not have that happen to you. My goal is to take that concrete thing that you've already seen in your life and make it a motivation, because what we're talking about is decades of taking medicines for largely asymptomatic conditions in order to prevent that catastrophe 20 or 30 years down the line. That's hard. And we're not really typically as honest with ourselves or with our patients about how hard that is, just because we know it's the right thing to do, right? We know that's the right thing to do. But helping our patients understand why it's the right thing and why they should put in the effort up front is so important. So both of these young ladies were on metformin. I probably gave them a little bit of a dose of an ACE inhibitor, and we were all good. And then they came back and they said, you know, I don't think mom's getting what she needs. Mom's A1C was 17. Any clinicians in the room want to tell me what that means? Yeah. Uncontrolled diabetes, great. So like I said, a normal A1C for somebody without diabetes is 4 to 6. What kind of blood sugars is she running? Yeah, 400 or 500. So the formula is you subtract 5 for that normal, And then every point above 5 that the patient is about a blood sugar of 35 average over the last 3 months. So she runs about 500. That's, if she had acidic blood, that's high enough to admit her to the hospital today. If she doesn't, it's still high enough to be causing silent damage to her brain, her heart, her lungs, her kidneys, her eyes. And in fact, she did have some blurriness in her eyes. So, so the chances that running sugars that high are going to contribute to early blindness was the really acute problem that I was most worried about, besides, was she in a life-threatening situation already? We did a urinalysis. She didn't have ketones. She didn't have acidic blood. So she wasn't in an acute, let me send you to the hospital emergency. But we had to do something. And what was being done wasn't working. So what other kinds of questions would you have? Great. What's her diet? So what kinds of things are you looking for in her diet? Yeah, is she eating a lot of refined carbohydrates? Can she afford healthy foods? Does she have access to healthy foods? Does she live in a food desert where fruits and vegetables are hard to come by? She raised 4 kids and lived all over the world, so I know she knows how to cook fruits and vegetables, but whether she has both financial and geographic access to them is a different matter. What else?
What's interfering? If she has a doctor, she probably was prescribed medication. What's interfering with her treating herself so far?
Great questions. Yeah. So what are her barriers? Has she been prescribed medication? She had. Is she able to afford that medication? How much does insulin cost? It depends on your insurance. Excellent. So what's the cheapest place to get insulin? Good guess, yeah. So, so as was already pointed out, it depends on your insurance. So this is a lady whose husband is retired Army, so she's got TRICARE insurance. It's going to be pretty good in terms of her copays. If she had no insurance, I'm sending her straight to Walmart. You can get regular insulin and NPH insulin for about $25, $30 a vial at Walmart. That is the cheapest it's out there. The branded newer insulins, if you get them in the pen form, the retail price without insurance is $500 or $600 a box for 5 pens, which depending on your insulin dose might be enough for you for a month, but you might actually need 2 or 3 boxes for a month if you have really serious insulin resistance. Some type 1s do, type 2s do. If she's taking vials, it's a little cheaper, but even vials, you're talking about 1,000 units of insulin for about $250. I did rule out cost as the issue in terms of her ability to take medication. So then what else is going on? Should she be on other medications? Is this a diet question where I've had diabetics where there's no amount of insulin in the world to cover cornflakes because that's just such a high glycemic index food. That's it, you know? And so you have to balance. I've also had patients where you had to balance their Lasix dose with their bacon, but that's another story. So what are her other barriers? So what other barriers might she be thinking about? Exercise, great. So is she exercising? If not, what are her barriers? What kinds of barriers would you be worried about? Yeah, what neighborhood does she live in? So I trained in Philadelphia, so she would have lived in a neighborhood probably near the university. There are places where the sidewalks are not kept up. There are places where there are no sidewalks. There are places where risk of violence is a big factor. The YMCAs in the city did have a sliding scale for access to their gyms, but was there one available to her? Would that have worked for her? So what would motivational interviewing tell me? So motivational interviewing is a fancy way of saying, let's ask the patient. Because if the patient comes up with the idea, then they're much more likely to come up with something that is feasible, and they're much more likely to be bought into that idea. It's my idea, but if it's their idea, then that's a different matter. Okay, so she was on a daily regimen of 2 shots of 70/30 insulin. She had to eat at specific times to match her food to that insulin regimen. And as I said, the A1C of 17 suggested an average blood sugar of about 500. So here's your quick study on the insulins available pharmacologically in the United States. So rapid acting is what we typically will use for mealtime insulin these days because it acts within about 15 to 30 minutes, peaks within about an hour, and is out of the system in 3 to 4 hours on average. That matches your food intake beautifully. Regular insulin is what was available before that and is still what's available, and that's what you're going to get if you go to Walmart. That's a little trickier because it takes an hour really to kick in fully and lasts 5 to 6 hours. So she's really going to have to take that insulin an hour before her meal. And then I had a type 1 diabetic friend when I was in college, and when the meal was late and he'd already taken his insulin, we're kind of stuck. You know, now he's going to have a bunch of carbs just so his sugar doesn't bottom out before the entree shows up. It gets messy. So while it's a great solution to keep people healthy, especially if it's the best they can afford, most endocrinologists, most docs are going to try to get somebody the more rapid acting insulin if they can. Intermediate insulin, NPH, was the best we had for long-acting insulin until about 20 years ago. And just over 20 years ago, we got glargine and I'm blanking on the other generic name, but the long-acting insulins that on average last about 24 hours. And so if you're trying to match the physiology of people's own pancreas and their own food intake so that you have the insulin at the time you need it, that glargine and fast-acting insulin is really your best hope. Here's what it looks like if you're trying to dose the 70/30. So it's a mixture of NPH and regular. So some of it's going to peak on the early side, some of it's going to peak on the later side. And you basically, if you're going to take a fixed dose every day of 70/30, you got to eat the same amount of carbohydrate at the same time of day to match the peaks of the insulin in order to make it work. On the other hand, if you have a fairly stable life and you can take these things on a regular basis, that can really work for you. Young people, folks who travel a lot, folks who are in college, kids who sleep in, have a harder time doing that. But it's a good fixed regimen for somebody who has a very stable schedule. And this is just showing you the 2 insulins that are overlapping that produce that upper curve. So I wanted to do the right thing for her. So you're going to help me on whether I did the right thing and whether we could have done something better. So this, again, these young women had trusted me with their mom. And I was, to be frank, a little bit outraged at the crappy quality of the care that she was getting just based on this, this A1C of 17. Now, I didn't actually have records. I didn't talk to their doctor. I don't know what they were thinking. You might think after I tell you what happened with us that I was a little cavalier about that. But so I showed her those beautiful graphs. I said we started the glargine. Cost was not an issue. I am not sure I was smart enough to ask about that ahead of time, but I should have been and now I would because it is expensive. But the glargine was easy. The problem was the Lispro. So has anybody ever tried carbohydrate counting to figure out? Yeah, okay, so we have a couple in the back. So tell me about your experience with that. Okay.
We're both dietitians, so this is what we're trained on. But educating a patient on carbohydrate counting may seem kind of basic for us, but it is not basic for a patient who's just been diagnosed with what could potentially be a life-changing disease. They're scared, they're unsure of what to do, and we normally get anywhere from 30 minutes to an hour to try to cover all of this stuff. Maybe they come back, maybe they don't. More often than not, we may not see them again. It's tough. It's really tough, especially with a follow-up that may or may not happen. We have no idea if they're actually counting their carbs or not. We're just trusting in the system.
Yeah. I'm gonna ask you, yeah, go ahead.
And then there's also like you don't eat single foods, so you eat composition dishes with carbohydrate, protein, and even for people to understand what is a carbohydrate, what is a protein, what is fat, where to find information. Not all like foods will have the label with the amount, and then you go also with mathematical skills on how to count at the time. So it's very complicated.
Thank you. Thank you so much for your expertise. We'll want you back in a minute, okay? So here's, in case you eat packaged foods or fast foods, here's one option. So you got to learn how many grams of carbohydrates in the foods you typically eat, know how many units of insulin are going to cover that. So that's going to be a collaboration between your dietitians and your endocrinologist or your internist or family medicine doctor to help you figure out what is that patient's ratio. Has anybody ever heard of something called the dawn effect? Yeah, can you tell us what the dawn effect is? So some people's blood sugars dip really low at 2 or 3 in the morning, and then their body produces adrenaline and shoots it back up by about 7 or 8. That's called the Smorgy effect, something like that. There's a name for it. The dawn effect, the pure dawn effect, is simply the liver's gluconeogenesis response, the liver's response of making extra sugar in response to the cortisol and the adrenaline and the other hormones that your body releases as part of your normal morning circadian rhythm. So people who have big dawn effects can be, say, 95, a normal fasting blood sugar when they first wake up at 6 or 7 or 8, and can continue to climb even without eating because their liver keeps producing sugar in response to those hormones rather than sugar being as part of the release of insulin with breakfast and all that. So some people, because of the dawn effect, that carbohydrate to insulin ratio will be different for breakfast, lunch, and dinner. How does that complicate your math? Yeah, good luck with that. I had one patient whose ratio was 1 unit of insulin for every 2 grams of carbohydrates for breakfast, 1 for every 3 units for lunch, and 1 for every 4 units for dinner, for instance, or 1 for every 5 for dinner. So there's lots of tools out there, tons of them. You can download charts like this. You can buy little books. You can buy books like the one before. You can use apps. So surely, oh, and Lily produces this nice chart you can fill in to do the math for you. So again, what's your food? How many grams of carbs in it? How much did you eat? How does that add up? So this meal is 75 grams of carbs. Now say your patient has a ratio, just for easy math, of 1 to 3. Actually, a type 1 diabetic is going to be more like 1 to 50. So that type 1 diabetic with 1 to 50 is going to take 1.5 units of insulin for this. If you have a type 2 diabetic who's very insulin resistant, who needs 1 for every 5 grams, they're going to take 15 for that same meal. So again, it can get a little tricky pretty quick. So what could go wrong? We're all set. She's 63. She grew up in the South. She has plenty of life skills. She gets admitted to the hospital. They put her on steroids. What happened? Yeah. Blood sugar's back to 500. So that's okay, because she's in the hospital, and we know what to do when somebody's sugar is 500. What'd they do? Yeah, they put her on a sliding scale to cover those high sugars from her steroids. So now she's got that single dose for her basal insulin that lasts all day. She's got the 3 or 4 doses for her meals and snacks that she's calculating using that easy-to-use chart that I just showed you. And she's got to take her blood sugar before meals. Remember that they decided she belongs on the middle of this chart of 3. If they're Please tell me they didn't give her the chart that has all 3 columns. Maybe they gave her the chart with just 1 column, but whatever. So she's on the medium dose scale. Her blood sugar before her meal was 150, and she had 75 grams of carbs. How much Lispro is she supposed to take? So doctor calls me up and says, oh my God, I can't discharge her. I'm terrified. She's going to take too much. She's going to take too little. She could either have worse complications down the line, or she could be found unconscious in her house or dead because she took too much. Dude, I screwed it up. So, one, what should we do now? And what could we have done better before?
Just from your basic case study, it looks like for endocrinologists, essentially just said, here's your meds, out the door you go. I'm assuming there was no education on diet, no education on exercise, no asking the patient, doing feedback like we talked about before. I have a microphone, I'm sorry.
Yeah, that's all right.
I'm used to projecting.
Yeah.
Yeah, I mean, there was a lot of steps
right.
that were missed here.
Right.
A ton. I
Yeah.
mean, not to mention, what is the patient willing to do? I mean,
right.
This is very paternalistic.
Right. Right. So this is my 1st or 2nd year out of medical school. I'm in an under-resourced resident clinic. I'm sure I didn't send her to a dietitian. I'm sure we talked about exercise, but probably in the 5 minutes or less. I am sure that I scheduled her to come back to my next available, which is probably 3 months. Maybe it was longer. I didn't have a diabetes educator to send her to. Her insurance might have actually paid for some of those things if I'd known how to access them or had access to them. But this was a general medicine clinic. This wasn't an endocrinology office. This wasn't a place that was set up with all those supports. But she clearly needed them. And I blew it by not getting those to her. What else?
One of the things that I run into a lot is patients just saying, I can't do that. I just can't do that. Like, my life isn't that predictable. I don't know from day to day what I'm going to eat. I don't even know what's going to be available. I just can't do that.
Yeah.
And they say that when they tell their physicians that, they get a lot of blaming, right? This is your life. Why can't you do it? And the other thing is, a lot of times what I've heard is people who already have eye damage can't accurately dose their own insulin. They can't even see, even if they can do the math, they can't accurately dose their own insulin. And that seems like that would be a huge problem maybe for her.
Yeah, absolutely. So there's one brand of talking glucometer for the blind to help them with that piece, but that doesn't help you see those little numbers on the insulin pens or on those tiny little insulin syringes. So yeah, being able to see well enough to dose the insulin is a huge problem. Grossly underestimated something much simpler. She wanted to please the doctor. I talked to her about this. I explained what I thought the best thing would be. I drew graphs. I asked her if that was okay. I asked her if she could do that. And she wanted to please me. And I just didn't have the presence of mind to appreciate the importance of instead of saying no, she said yes, when she should have said no. And part of it is, of course, that when she got admitted to the hospital, her regimen got infinitely more complex. I don't think I could have followed that regimen, and I don't know many patients who could have. And actually, the hospital folks knew that. That's why they called me as her outpatient doc to try to help come up with a strategy. So I didn't get her a diabetes educator. I probably tried to get her a dietitian. I don't know if I was successful. But what I did do is call her daughters and say, as a family, let's sit down and think about this. What can we do? How can we keep mom safe? How can we make sure she has what she needs? I talked with both daughters. We talked about how to do these calculations. Until she got off the steroids, I didn't see a good way to get her off the sliding scale insulin, but that was my next move. And we were hoping that that would only be a week or two. In the meantime, her daughters did have the math skills to help her, and so we gave her some guardrails. Your dose should be running about 5 to 10 for a meal. If it seems less than that or more than that, check with someone else so that we can make sure that we're getting you the right amount. In the meantime, we're going to get you back in the clinic. We're going to get you more education, and more importantly, we're going to simplify that regimen. Oh my God, what were we doing? So combinations of other medications. Are there pills that we could give her that would give her more insulin sensitivity that would help? Are there other things that we could do with her basal insulin? Maybe we make most of the insulin basal and get rid of the mealtime insulin altogether. We should be able to get rid of that sliding scale as soon as she is off those steroids. And there are insulin secretagogue pills that we could have her take a half an hour before the meal. Again, just so that she doesn't have that complexity in her regimen. And as Dr. Bourne pointed out, what does she want to do? What is she able to do? Really, again, trying to pay much more attention to not just what's the best thing, because the best thing is not the best thing if it doesn't work. And it's not the best thing if it's a plan the patient can't carry out, whether that's for financial reasons or for logistical reasons or for other reasons. As we think, just putting on my ethicist hat, asking her what she wants, what are her goals, and offering her a choice of approaches to how to get there so that we can come up with something that is feasible, is respectful of her autonomy and is respectful of her as a person. Beneficence, obviously doing the right thing by her and not hurting her by giving her a regimen that really could put her life in jeopardy. As a clinician, I really want to learn about my patients, and it is not just small talk. Where do you live? Where did you grow up? When I'm working with veterans, where did you serve? For couples, how long have you been together? What do you enjoy doing? What do you do for a living? Those things give me information about this patient, about their expertise. In her case, my guess is that she had about a 3rd grade education just based on where she'd grown up and when. This is pre-Brown versus Board of Education, keeping in mind. What I have found when I do ask people those kinds of questions, I learn what their skills are. I learn what metaphors will be helpful. I learn how to draw on their expertise. And I learn how to show respect for them as people and respect for their expertise. Teacher, tell me how you would explain this if this was your student. Again, so that we're doing a teach back, but in a way that is respectful of her expertise and draws on her own expertise to help support her health. I took care of a plumber once who had pneumonia. And he said, "Doc, why isn't the stuff coming out?" And I said, "Well, look, I'm no expert in what happens when the diameter of a tube drops by 50%. Can you help me with that?" And he just started laughing. Because of course, when the diameter tube drops 50%, your flow volume drops dramatically, your flow speed increases. Of course, he couldn't cough up that stuff. I once had an engineer who wanted to leave the hospital against medical advice, and the docs wanted to keep him because his potassium was low, and they didn't know what to do, and he was really upset, and he was throwing a fit, and I said, "He's an engineer, show him the graph." We showed him the numbers, and he was ready. And I took care of an electrician just in the last couple of years who had a tumor wrapped around his spine. The neurosurgeons took out as much as they could, and then after about 6 months, it grew back. His 20-something-year-old son was really upset that we had screwed up and done the wrong thing, and was, of course, terrified for his father, as were we all. And I just looked straight at the patient and I said, "They can't just cut the wires. All those nerves coming out of his spine, the spinal cord, and all those spinal nerves, you can't just cut the wires." It took him less than a second to be like, "Yeah, you can't just cut the wires." And so even though we couldn't cure his cancer, he understood in a way that concrete as possible, drawing on who he is as a person and showing respect for his skill and expertise. Just a few other critical things that I'm sure you heard some of before, and you'll hear some later. non-English speakers, please, please, please don't use their kids, please. Because the case I had 3 weeks ago where they were using the daughter from the first marriage to translate for the stepmother just didn't go well. I don't know why. But also family members may not have accurate information, may not know the right vocabulary to describe these things, maybe trying to protect their loved ones. I get one ethics consult every 6 months for family doesn't want to tell so-and-so they have cancer. I have a whole spiel for that I can tell you later, but if they're doing the translating, maybe they're not telling them they have cancer. So please, we have great translation services here, use them. For folks who are deaf and hearing impaired, there was a rheumatologist in New Jersey who lost a suit because a woman had lupus. She was seeking care from him. She requested a sign language interpreter. He said, sign language interpreter gets more money than I'm going to get for the visit. Well, it turns out that under the ADA, that doesn't matter. Under the Department of Health regulations, that doesn't matter either. And she sued and he lost. And the judgment was not covered by his malpractice because it was a discrimination, not a malpractice judgment. My 5-year-old boy is visually impaired, so I have a special place in my heart for making sure that, both folks who are deaf and blind are getting access to the information they need. And again, this is a respect for persons question. How do they normally access information? Most people who are blind do not read Braille. So we have it in Braille. Only about 30%, 20 to 30% have been taught Braille, partly because blindness covers a spectrum that is much larger than no light perception. People who are legally blind, it's 2200 is the criteria. But also over time, there have been a lot of issues with schools actually being willing to teach Braille because it's one-on-one instruction, it's expensive, yada, yada. Believe me, I could bore you all day about this. But the critical thing for our patients is large print going to be helpful to you? Is Braille going to be helpful to you? Do you need your discharge instructions and your prescriptions described in an audio recording? Can we do that on your iPhone? Can we sit down, go over everything? You can record it on your iPhone, then you can go back over it later. Would it work to give you a PDF or a handout that you can use your home OCR text-to-speech protocol? Whatever it is that they have access to and are used to doing, that's how you're going to provide the information, just like you would for anyone else. And when in doubt, ask the patient. They really know themselves. They really know their health. They really know their capacities. And if you are sincere, they would love to work with you. That's it. Other thoughts? Yeah.
You make a really great point about making sure you're using official medical translators whenever we're talking about dealing with patients who speak foreign language. We had a case like this just last week in the geriatric clinic where I precept. All of the information had been obtained from the patient's child, adult child. We were told that the patient had an 8th grade reading level, and it wasn't until we actually sat down with the translator after we had already given a cognition exam and found out that the patient actually has a 3rd grade education as opposed to an 8th grade, and we were giving the wrong test the entire time. So it's so very, very, very important to use those translators.
Embarrassment. I mean, I won't even start telling you the stories about OB cases where we're using minor children as interpreters. Please don't do that.
Hi, I wanted a couple of points. One, and question. I really appreciate this idea of translation, but as you mentioned in and I want to point out in your presentation, translation is not just language. It's also translating what the messages that the medical providers had to say to the patient. So a lot of the examples you gave of relating to that patient directly is a form of translation.
Yes.
And I think that's important for folks to know that it's not, when we talk about translation, it's not just Spanish to English or one language, a different language, it's also creating a high level of understanding.
That's right.
And the second point I wanted to say, and comes with the question, is the case study you mentioned was really great about, I really appreciated about how you went about solving that. I think one of the things that we overlook as institutionally in clinics is the community's role in helping solve some of these issues.
Yeah.
Like tapping into community-based programming that supports diabetes education and help with adherence and understanding and translation to patients. So if you have a patient from an underserved community or underrepresented population, there's probably a program in the community that helps them to understand whatever is their condition, particularly on the larger chronic disease states like diabetes. There's going to be, we have at least 3 DPP programs I can think of off the top of my head that affect every population that we have in Wyandotte County. Most populations we have in Wyandotte County, even including the police. So make sure that we consider those community-based programs when we're making a diagnosis or a referral to support that the prescription that you give. And do you have any? I may have missed you saying that earlier, but did you have some examples of where you made that connection? Or
You are completely right. And at that time, I didn't, even though Philadelphia is also rich with community-based organizations that could have been helpful to my patient. I was just not aware of them. I spent 3 years after that in Detroit, where I worked directly with those community organizations. So the question is, how can we make sure that our clinical colleagues and our trainees are learning about those community resources? That it's not just siloed with, well, the social worker will take care of that. And this speaks partly to the issues, again, about professional formation. What is it that a doctor is supposed to know? And doctors are supposed to know how to interpret lab results, but doctors also need to know their communities, need to know the resources that are available to their patients. I couldn't agree more.
I just want to share a thing that I learned working with the Latino population here that was very interesting related to language. So we were doing focus groups about barriers to prenatal care among pregnant Latinas. And then we have a case of participant sharing that she was with her OBGYN, that he kind of speaks Spanish and she kind of speaks English. And she was saying about all this communication that they had. And during the focus group, we were asking, why didn't you ask for an interpreter? Or why did you decide to go with your kind of English? And she was saying, oh, because sometimes it takes too long. I wait too long for an interpreter.
Yeah.
But at the same time, I cannot highlight how important it is for the physician to include the patient. Because if he would have done, I imagine, the teach back, maybe he could catch her English was not proficient enough to understand everything he was explaining to her.
Yeah, I completely agree. Yeah.
It goes more than just the language, but also how proficient that is.
Right, right. And a lot of times we're talking about people who are not speaking common languages. In our refugee populations, we often don't have access to telephone translators. We may have folks who are trying to use a translation that is a dialect that is not quite theirs. So out of respect for our next group, I'm going to wrap up. But thank you so much for your help. And too bad we didn't have you guys together when we had this poor lady. But we got her the help she needed, just not quite when we should have.
Thank you, Dr. Kern. Thank you. So we're going to set up for our next speaker, who is actually going to be speaking to us from Salina. So we're going to be the recipients of Zoom technology. And I think that we've got our IT people on that, and Jennifer will do the introduction here in a moment. I did want to add something. We're talking about using the community, and I think we often want to look at other populations and say that there's something missing. One of the things we do here at KU is we send our students out internationally to observe health and health delivery around the world. We have a lot of great examples of community health programs, one of which is at CMC in India, in Vellore, India. Excuse me, I can't get my throat to clear this today. Our students go abroad to learn about how things can be done better in the United States and to compare and to learn. And that's one of the things. And at CMC in India, that the whole family and community is involved when someone is ill. And part of the process of education is very inclusive of that family and the community. Our students come back with really great, informed and excited about how this could transform our own healthcare system.
Yes.
Uh-oh, did we lose you?
We're here, Mike. I see you.
Okay, perfect. It looks like we lost you, but that's...
I stopped sending content, so you'll need to send content, I guess, from your end.
Oh, I thought we were.
I am not seeing content now.
Okay, let's try this.
You go down to share and then...
Yeah, we were there a minute ago.
Okay, I am now seeing it.
Let's see if...
So I am seeing your presenter view on this end.
Okay, we want to get rid of that.
All right, I think we look good on this end. We see and hear you.
Beauty.
So this is a new experience. So you are our first participants in trying to do some sharing with our campuses throughout the state. And in our efforts to be inclusive, we want to make sure that it's not always us trying to reach out and project our presentations here in Kansas City to these other sites, but really taking advantage of the opportunity and the technology to hear from our experts throughout the state and come back this way towards the Kansas City campus. So bear with us as we work through this technology, and we're so glad that we're able to do this here today. So at this time, I'm going to introduce our next speaker, and I'm going to do my very best to pronounce her name correctly, and so please correct me if I'm really off. So Dr. Nazra Azadani serves as the emergency medicine clinical pharmacist at Salina Regional Health Center. She received her Doctor of Pharmacy degree from the University of Kansas, completed a pharmacy residency in Salina, and holds a teaching certificate through the University of Missouri, Kansas City. She serves as the primary preceptor for the emergency medicine pharmacy rotation. She is the pharmacist representative of the emergency department, stroke and chest pain committees, and serves as the secretary of the hospital's diversity committee. She participates in numerous community engagement activities, including first responder education, emergency preparedness training, and outreach aimed at increasing the involvement of young women in STEM fields. And so today we will be hearing from Dr. Nazra Azadani about pharmacological perspectives on our topic of health literacy today.
Thank you. Hopefully you can hear me okay in this remote setup here. Yes?
Yes.
Okay, perfect. Thank you. Well, thanks for having me. I know the remote connection is sometimes a little bit cumbersome, so I appreciate your patience and your graciousness in hosting me. So thanks very much. Zara is just fine. Nazra Azadani is a lot of syllables, so Zara works just fine for me, and I'm going to try and manage technology on my end as well. I am a pharmacist, and so slight bent in my perspective here, and hopefully it adds a little bit of something to the conversation. Obligatory disclosure statement, I have no conflicts of interest to disclose. Maybe one day when I'm making a little more money, I might have something to disclose here, but not yet. And so I have just basically lifted these objectives from the overarching objectives of the unconscious bias conversations. So these should look familiar. They're nothing that I came up with, and I just used Kimberly's objective about how to make this connection between pharmacists and the topics that you're already discussing. So unconscious bias and health literacy, how those interplay and what pharmacists can do, and how we can be involved in that. So again, nothing totally new here. I'm hoping that these will be things that are a little more clarified, that the audience will be able to do and understand by the end of my presentation. And so just to give a little bit of context here, and sort of by way of some explanation as to what in the world, how the connection came to me, I work in Salina, as was mentioned in my little bio earlier, and the KU School of Medicine is also here in Salina in central Kansas. And so I sort of juxtapose these couple of images here. Salina Regional, the hospital here, serves about a 90-mile radius. When we're talking about bridging some disparities, especially with rural health, that's something that we're pretty focused on, but lots of facets to that. We're about a 200-bed hospital, again, a regional hub, and we work very closely with the KU School of Medicine, not just the students that are in the hospital kind of doing their clinical learning, but also many of our pharmacists, myself included in the fall, participate in some not quite didactic, but flipped classroom type learning scenarios with the students here. So there's a very vibrant relationship that I'm excited to be a part of here in Salina, of all places. And so this may be a little bit rudimentary. I was listening into some of the conversation you all were having, and I'm used to this being a brand new conversation for folks. You all are, sounds like, more at the grad level, which is very exciting for me. This is one of my favorite things to talk about. But I did want to kind of meet those objectives that we had talked about. And I'm sorry if this is repetitive. It's kind of, I'll give you my spin on it. Hopefully it's a little bit different than some of the things that you've heard before. But first, I wanted to talk a little bit about what health literacy is, just definitionally, and I broke out this one sentence into each component part to show you that it is a little bit more complicated than maybe we think about or expect it to be. And so these are a lot of moving parts for patients and families to have to navigate. The ability to not only obtain, but then interpret and then next level understand information and services that are being provided to them or at their disposal, and then how to make use of that information, how to access those services, and then to further enhance their health. So this is a lot to ask our patients to be able to do, and I like to do kind of what I consider the grandmother test. So do you think that your grandmother could accomplish the things that you are asking them to do? And as maybe another way to think about that, if you were explaining how to use an iPhone to your grandmother, would they be able to understand the way that you're explaining it in such a way that they could send you a text message or use an emoji? And obviously a little bit of a millennial bent to this conversation as well. But if you think about the disconnect that might have between yourself, the explanation that you're offering, and the intended audience, you can see, if you've ever been involved in these conversations, how that can get a little bit complicated and in over your head in some instances. And so further, health literacy, and this is kind of the way that we talk about it even in our didactic courses in pharmacy school, it's very strongly correlated to patient outcomes. And that correlation, if you were to do statistical analyses, is a stronger correlation, so approaches 1, more strongly than any other single factor. So yes, those other things that cause us to approach our patients with bias do also have a strong correlation in their outcomes. We know that we tend to do a worse job helping our patients of color and helping other marginalized groups, but even more strongly is our patients' health literacy. So this is a stronger correlation than income, employment status, education level, and race. But it's also somewhat hiding, so we may not immediately see that. We could potentially see someone's skin color the moment they walk into the room. We might immediately notice their hijab or discern that they have limited English language proficiency, but their health literacy may be something that not only is not apparent, but they may be actively hiding from us as practitioners. There's a lot of stigma and shame associated with those kinds of limitations. It's also extremely costly. So later on, when we talk about some of the monetary impacts, these dollars amount to a huge toll on the health system overall. So $50 to $73 billion, like B with B for billion, not M for million. So That's a huge cost to the health system, and that cost harms patients. So it's not just a question of saving money for the health system or for the country, it's a question of there's limited resources, and when we sink them in things that are preventable, there's less to go around. Our patients with lower health literacy also are prone to more hospitalizations, more medication errors, something that I'm especially interested in as a pharmacist, and also this really important patient-centered outcome of mortality. So these patients are dying earlier, leading to something called a mortality gap. We literally have fewer human beings in existence because of things like poor health literacy, and also things like implicit bias in the way that we treat those patients. So this actually was just on my Twitter feed, and we'll talk a little bit more about the role of Twitter, I think, a little bit down the line here in a few slides. But I think that Twitter is, and surprisingly, a useful tool for addressing some issues that we have in medicine, things like the knowledge translation gap. So a new guideline comes out. How long does it take us to incorporate that best practice into our day-to-day routine? Used to be something like 17 years and has closed to more like 6 to 12 months. And it's through open access things like Twitter, of all things. So we'll talk about that a little bit more in a minute, but I just happen to see, you can see this tweet's from the 24th. This is a physician who I follow and is very active in some open access medication movements. But they say, I was frustrated because a parent wouldn't or couldn't get insulin for their child, even though it would be covered at 100%. How could they let that happen? It's because they were functionally illiterate. So not just poor health literacy, but this is a patient who could not read or write. And so that, again, is something that is not immediately apparent, is not something that people are willing to disclose. And I kind of had a few other statistics to go along with this slide. There are 32 million adults in the United States who can't read. And that's a huge number. According to the Department of Ed and the National Institute of Literacy, and 50% of adults can't read at an 8th grade reading level. So when we're crafting medication information, again, as pharmacists, providing information to patients, crafting interventions, we're kind of aiming for an 8th grade, 6th to 8th grade reading level, and that's what the NIH recommends that we do. But there's a huge percentage of the population, the adult population, that we're not reaching even at that level. And so this is something, in addition to health literacy, just plain old literacy, that we need to be thinking about. There aren't necessarily universal screening tools for this that are being used. You can kind of think about where you work and if that's something that you're addressing, but often this is not a thing that we're thinking about or considering as a pitfall. So again, a little bit maybe rudimentary here, but I wanted to talk about implicit bias so that we get a good grounding of how these might interplay. So implicit bias is a bias in judgment or behavior or both. And it's cognitive processes, so it's our attitudes and stereotypes that we bring to the table, but it's below our awareness. So some of these things we know that we're doing, but implicit bias are the ones that kind of sit below the surface. They're unintentional, and they're difficult to control, hence unconscious. So the trick then is to bring these to our consciousness. We don't know that that's going to solve all of our problems, but we do know that there is a discordance between people's explicit bias, so how biased they believe that they are, and then when we take implicit bias association tests, the actual level of bias that manifests in our everyday behavior and attitudes. And because of that discordance, it means we're not aware of the things that we might be doing to patients. So there are some intersections here that we need to think about, and that is a term that comes up, and you all may be very well of this, but intersectionality is something that's extremely important, because when we talked earlier about health literacy being the most strongly correlated to patient outcomes, although that is true, usually patients are not just low health literacy. We are a multitude of identities all interacting together. But when we boost health literacy, we actually afford a protective layer to our patients. We empower them to be able to make decisions and have some input and say into their health decisions. So this lower health literacy also strongly intersects with health disparities, both in access and the quality of the care that patients receive and their patient-centered outcomes. So in short, we need an interdisciplinary approach because there are lots of moving pieces here. And so that is one layer where pharmacists can be involved. The patients with the least or lowest health literacy are also more likely to be in those groups with the greatest risk for the impacts of implicit bias. So patients of color, patients who are undocumented, all these different marginalized groups that we're likely to harm are also very likely to have low health literacy. So there's a couple reasons or proposed reasons why we might have this effect on our patients. Our patients with low health literacy tend to have a higher illness burden, especially chronic diseases, and we know that those enact a toll on a patient population. They're also more likely to have occupational risk and exposures, and just by surviving and making a living, more likely to be unwell. They tend to have a lower health awareness, which means that early recognitions of symptoms, which are so important in things like stroke and heart attack, may not be there. They may not have the tools available to help them recognize what might be going on, what high blood sugar looks like over time. And then there's this whole complex health system that's broken and fragmented that is hard to navigate even for, let's say, healthcare providers at times. And so to expect a patient to work through that, again, the grandmother test is a tall order. And then patient adherence is a problem. I'm glad that we stopped saying compliance, but adherence is sometimes intentional and sometimes unintentional. So if someone has low health literacy, often adherence or lack of adherence is unintentional, but sometimes it's a distrust of a system that patients know harms them. So they may not know all the reasons why they distrust a health system, but we know for a fact that we are doing harm to patients in these marginalized groups, and it makes sense then that they would not want to be a part of that. So in healthcare in particular, I wanted to highlight just the fact that we as healthcare professionals, our bias is exactly comparable to the general population. So we like to think we have higher education, we have all this evidence-based medicine training, we are taught to think objectively and like scientists, but we really don't do a better job than the average population at resisting the effects of implicit bias and doing right by our patients. And so it really is something that we need to work at, that the work isn't already done just by means of our educational training. We know, for example, that across the board, healthcare providers favor white patients over patients of color. Patient outcomes in patients of color, especially our Black patients, are lower, poorer. That mortality gap is really significant in this patient population in particular. Most of the literature and research is about our racial disparities. So that's easy to find. It's, there's a scientific consensus that this is real. And that manifests most significantly in the way that we interact with our patients. So basically at the door. And then it makes sense that when those interactions are not good, that the outcome, the health outcomes, the end result is also not going to be good. So again, I can't really emphasize too much. We're harming patients and we're all kind of part of that. So these are a couple of the things that can happen, sort of the end game. So we either put up more barriers to care or fail to address them in our patients. We have decreased patient satisfaction, and I put a star by that because the folks that wear suits in the hospitals tend to really be interested in that patient satisfaction score. That's something that they really try and improve and make better. And so this piece of information in particular really tends to get the attention of people who can make decisions. We also tend to solicit input from our patients less when our implicit bias is at play, when there's low health literacy, and therefore we center the patient less, and we know that that's really important in getting good outcomes. So what we need then are system level solutions. We need interdisciplinary efforts. Again, I'm inviting myself to the party as a pharmacist. And this, kind of infographic is somewhat viral. It's all over different social media. But I just kind of wanted to point out that the first image is showing what equality looks like. Every participant has been given the same accommodation. The middle slide is about what equitable treatment looks like. So each participant is given an accommodation that meets their need as an individual. And then the last image here is what it looks like when we implement system level solutions. So at the point where we're fixing the root cause of the problem, we can eliminate some of those accommodations. We don't even necessarily need to intervene at that point, or our interventions could look a lot different if we remove the barriers in the first place. So the role of the pharmacist, kind of taking the long way around here, is that basically, and again, I'm going to spend a little bit of time kind of touting what it is pharmacists can do, but that we are able to intervene at every step of the healthcare system. So we're sort of at the front line of care. It's pretty easy to find a pharmacist and speak to them, I think, and we're sort of trained to be in this position, to be at the front line, to be the face that people can approach and access pretty easily without making an appointment and without waiting in line and that kind of thing. And then we do have the ability to impact direct patient care, both in the form of the actual care and service that we're providing in the form of pharmacologic interventions, but also indirect care, so engaging patients, bridging those gaps, addressing some health disparities, recognizing our implicit bias. But because we're folded into every stage of this process, while I think that we have the potential to do a lot of good, we are still humans, again, no different than the general population. And so our biases are especially important to address because we can also negatively influence those same patients. So one of the ways that we can do this is through our normal dispensing functions, and this is pharmacist speak for the thing that most people think of when they think of pharmacists. So the pharmacist behind the counter in the white coat, counting pills, screening for drug interactions, asking patients about their allergies. That's a dispensing function, so your typical retail dispensing function. But there's a lot that goes on behind the scenes. We resolve insurance problems, so for patients who are either uninsured and we're trying to find reasonable cash alternatives for those patients, underinsured, so we're trying to kind of work with a system that's broken to try and do the least broken thing for those patients. We also, in the past several-ish years, have implemented med sync or medication synchronization efforts to help identify adherence issues. So patients with chronic disease states on many medications or polypharmacy, we try and get those patients lined up so that all of the prescriptions are due at the same time. By doing that, if we notice that someone is not getting their metformin, but they are getting their other 10 medications, we've identified a red flag in their ability to adhere to their regimen. Maybe that means that they get severe GI upset when they take their metformin and it's intolerable, and they need to know how to address that or what alternatives are available, but at least we have a clue as to the thing that they're not able to adhere to. Speaking of uninsurance and underinsurance, we also get folks enrolled in Medicare Part D in October-ish when that rolls around. We help people get enrolled in a marketplace insurance plan through the Affordable Care Act. I have helped people get enrolled in the low-income subsidized Medicare D plans, and they had no idea that was even an option. They brought me a bag of oranges to thank me. It was really nice. But there are lots of things that we do, again, behind the scenes. There's a couple more I just want to highlight real quick. MTM and CMR, so we start to throw around this like alphabet soup. Medication therapy management and comprehensive medication reviews. They're very similar. They go hand in hand. But basically what they mean is we look at the patient, their disease states, all of the medications that they take, and we look for ways that they might be not optimized. So de-prescribing is important. Older patients who are on medications that cause a lot of harmful interactions or adverse effects. Just maintenance, so vaccinations and making sure that they're up to date on vaccines. Again, dangerous drug interactions, adherence issues that we might be able to address. Those are all kind of bundled together in one holistic, whole patient kind of intervention. And I also just wanted to point out, I didn't want all these slides to be just words. So I thought maybe I'll put in a nice little stock photo of a pharmacist counting tablets. It like took me several pages of Google scrolling to find a pharmacist counting tablets that was a person of color. So every stock photo I could find for several scrolls was a white pharmacist counting actor, but counting something. So I just wanted to point out, even something not specialized, it was really hard. So I wanted to be very deliberate about that and kind of be proud of myself a little bit. So a couple other retail pharmacy tools I wanted to highlight, and I heard someone mention earlier, I think the teach back method. So again, this may be old hat, but these are things that we're taught in school that we get didactic training for. So just a few to cover here. So Indian Health Services model is a way of counseling patients, providing information about medications that is very structured. It's a particular script that we follow, that we're taught how to do, that was studied in the context of Indian Health Services, or the IHS, because pharmacists have prescriptive authority. It's really a very cool system. It's kind of like the VA. So we're very, very hands-on in those government models. But regardless, this is one communication tool that kind of helps bridge low health literacy gaps by being extremely comprehensive. It's definitely got some pros and cons, but it's one of the things that we are able to do. The teach back method, which I have seen some pharmacists kind of implement this as, okay, what did I just tell you? What did I just, tell you that you need to do? Or what did we talk about today? And although the open-ended question piece of that is important, that's a really bad way of doing that. So it needs to be something more like, you're taking a blood thinner. What would you be looking for if you thought maybe the level of your anticoagulation was too high? What sorts of things would suggest that you're at risk for easy bleeding? When do you need to go to the hospital? Like if you fall and hit your head, that kind of thing. So asking open-ended questions, but with a specific purpose of highlighting the things that you really, really need them to know, and making sure that they're not just parroting things back, that they know the important salient points. And then Ask Me 3, I think is a thing, so I graduated in 2012, but I think it's a thing that must have happened a little bit after I graduated, but it is something that's being taught to the, more recently matriculating students. And it's, again, just a way to highlight the main points. So what is my problem? What do I need to do? And why does that matter? And it really sort of sums up everything that we need patients to know about medications, but in a very, like, my grandmother could understand kind of way. So that's all the pharmacist behind the counter in the white coat, which is an important part of pharmacy, is very important in chronic disease state management and managing the needs of the community. I'm going to be a little bit biased because I've done that, and now I'm in a hospital pharmacy. And so that's kind of the thing that I'm a little bit more interested in. But I wanted to kind of pull back the curtain on these things, because that is something that happens hospital pharmacy, much more behind the scenes, and again, kind of advertising for what it is we're able to do. Because if people don't know that we can provide these services, then you don't know that we're an available resource as part of the team, as part of the way that we might be able to help our patients together. So, for example, at Salina Regional, we have pharmacists in each of these specialties. There are many more. There are transplant pharmacists and entire roles for pharmacy committed to medication safety. We just have like a part-time piece of that. There are whole teams of pharmacists, informaticists, but we are pretty pleased with the fact that we can offer this many specialties in Salina, Kansas. I won't, read all those to you, but I wanted you to be aware that these are things that exist that we can specialize in, and that we can provide unique services for. So we're decentralized. Most modern hospital pharmacies are, when they have the resources available to do that, which means we're not all sitting in the pharmacy. We're scattered throughout the floor. We're going on rounds with clinicians and interdisciplinary teams. We're providing therapeutic recommendations. We're protocolized, so we can make certain interventions without consulting anyone. We can adjust doses and perform pharmacokinetic calculations and all sorts of things as a means, or through the process of getting those approved in a protocol at the hospital. So we have a little bit of autonomy in that way. So I wanted to highlight a couple of these roles that are maybe my favorite. So I might be, again, a little biased in that way, but this is one of my favorites because it's sort of a gap between community practice and the hospital. So we're talking about something that looks like ambulatory care, something that helps patients get back into the community. So these are mostly our patients in the hospital for chronic disease state mishaps. At Salina, these are our patients who are usually lower income because the internal medicine rounding group is the Salina family group, which is targeting that particular patient population. But our pharmacist with this team rounds with the medical residents and their attendings. So there's a very learning-centric atmosphere. They provide therapeutic recommendations based on clinical guidelines and best practices. And I put a star by that because we know that that is one of the ways that we can help address implicit bias, is when we're using evidence-based medicine instead of letting some of our less than desirable judgments come through, then we tend to do a better job of not letting those interfere with our practice. So for example, our diabetic patients need to be on statins because we know that that, helps their patient outcomes. Well, if we're making sure that we adhere to those evidence-based practices instead of saying this patient won't take their statin anyway because of X, Y, and Z thing that I perceive about them, then we're going to do a better job of making sure that we meet all those outcomes. And so we also are able to provide physician education in that way. And that's kind of one of the biggest things that this particular pharmacist does, is knows the guidelines, knows when to intervene, and knows how to help ensure that patients are meeting those best practices. This one I'm definitely going to be biased about because this is what I do, which is emergency medicine. And so I have even more bullet points on this one because it's one of my favorite things to talk about as well. But this is something that is relatively new for pharmacists to be doing. And so even more than some of the others, this might be the behind the scenes kind of thing that is unknown. But so in the emergency department, one of the cornerstone roles that we do is make antibiotic recommendations. So patients come to the emergency room, they get cultures collected, and then they leave because not every patient needs to be in the hospital. And so what we do is we look at those cultures and see if the antibiotics match up to what they grew, and we follow up. So they don't need to come back to the emergency room. They don't need to incur a copay for the doctor's office visit. We can call, see how they're doing, see if they need any further treatment, maybe change their antibiotic if they grew something that was resistant. We also let patients know about state reportable illnesses. So most of the time that means STIs like chlamydia and gonorrhea, but those kinds of interventions make a huge difference because the patient then knows how to protect themselves. We provide some education and try and eliminate the number of steps that are needed for the patient to get the care that they need. We also perform medication reconciliations. So we look at the patient's medication history, and actually at Salina we have a dedicated team of technicians for this. So although I'll do it when I need to, I'm really lucky because our technicians go and do this. But they visit with patients and they use various different resources. So not just asking the patients which medications they take and checking them off the list, but they call the patient's pharmacies, they call the patient's doctor's offices, they look at their external histories, and they reconcile all of those into one complete picture. And we know that this transition is extremely risky for patients. So hospital to home, home to hospital, things fall through the cracks and they get missed. And in helping address these for patients, we can kind of pick up some of the slack that low health literacy leaves behind. We look at adverse drug reaction monitoring. So it is staggering how many patients are in the emergency room because of things that their medications did to them. So we call these medication misadventures, and we monitor those, we keep an eye on them. At the front line in the emergency room, I catch a lot of these, and then we continue to watch them as the patient is in the hospital, address them with their providers, and try and get those fixed before they go home so that they don't continue to harm the patient. Again, those treatment guidelines, evidence-based medicine that we like to adhere to, we participate in emergency response, so we go to stroke activations and code blues. We know that pharmacists involved in those scenarios tend to mean that patients live longer. We make fewer medication errors in those high stress situations. And high stress, where we need to do some cognitive offloading and automate some processes, that's when implicit bias actually tends to be the most severe because we need it. We can't be thinking about, when do I do CPR in this person? It needs to be automated. But some of the other automated processes, like biases that you hold about particular marginalized groups, we need to try and eliminate. And so if we can cognitively offload some of the things in an emergency response, all the better for the patient. And then I mentioned earlier my love of Twitter. It's a love-hate relationship, but I kind of wanted to just give you this resource here. So I put a hashtag to remind me to mention that it's like a Twitter thing. But so FOMED is free open access med education. And so it's this principle of democratizing medication or medicine education. And so if we can, again, close that knowledge translation gap so that those best practices and those treatment guidelines are implemented as widely as possible as soon as we know they're the best thing to do, it means that we're going to be able to apply those to our patients more uniformly and, again, minimize the impact of implicit bias and low health literacy. There's lots of other things that our pharmacists do. So our cardiology pharmacists, for example, will perform follow-up phone calls for patients who are in the hospital for heart failure exacerbations. So the patient goes home and we call them and say, have you been checking your weight? We send them home with a scale and make sure that they're not gaining too much weight too quickly, which would indicate another exacerbation, that they're retaining fluids. And we kind of touch base with them. We have demonstrated that this tends to keep our patients out of the hospital. Our oncology group is working on developing some chemotherapy, oral chemotherapy adherence programs. So same kind of thing, checking up on patients at home, making sure they understand the importance of their chemotherapy regimen and how to take it appropriately. And then we, in the past 2-ish years, have implemented something called Meds to Beds, which is our outpatient branch. So when patients are in the hospital and they go home, there's about 100 different very good reasons why they may not pick up their prescriptions. But if we take them to their bedside before they leave the hospital, they're already in hand. They don't have to swing by the pharmacy when they're feeling crummy already. And it also helps with adherence. So they don't have to navigate some of the insurance pitfalls and problems that could happen if they're just sent into the world by themselves. We also provide, through the philanthropic arm of our hospital, which is called the Foundation, prescription assistance. So for limited days of therapy, and there's a monetary cap, but some of these medications for patients who are uninsured can be completely covered for like a 2-week supply to at least get patients through that vulnerable gap period. We hook them up with social work. So we have a lot of more traditional kind of interventions for helping address health access disparities and lots more. Again, I'm very proud of the work that we do here. And so just trust me, there's a lot that we do here. So the scope of hospital pharmacy kind of overall doesn't really necessarily always lend itself to those siloed definitions and specialties. So we engage in patient safety initiatives. We perform something called medication utilization evaluations, or MUEs, because that's a mouthful. And when those MUEs are targeted to say, how often are we making this particular clinical intervention in patients of color? Or are we even asking our patients, you know, if they are LGBT, and collecting that data until we ask the question, we don't know how we're affecting those patients. And there's definitely still some work to be done there. Formulary management is a big piece of cost savings. So we don't necessarily offer every single medication in the hospital, and we're able to then use those savings to optimize patient care. Pharmacists are involved in interdisciplinary committees, and so we're able to enact some of these interventions at every level of the hospital, including at the level of leadership. So we're involved in executive level committees, and then also just the academics of it. So performing research, training students and residents, seeking publications, all the traditional kind of geeky academic stuff. We like to definitely do that. So pharmacy education itself has health literacy issues and ways to address those built into the curriculum. We talked about the IHS model, the teach back method, and all those different communication tools. During preceptor training this past January, the deans at the pharmacy school for several years now, but most recently have been talking about entrustable professional activities, which I think are mostly built into med school curriculum by now, but it's sort of a newer thing in pharmacy land. And in particular, so basically what these EPAs do are they assess the level of independence at which students are able to function doing the things that we expect practitioners to be able to do. But in particular, they folded in this metric that makes sure that they include and address social determinants of health, which of course we know to be important in addressing implicit bias and health disparities. And then we also, when we precept learners on rotation, we can do some of these things that we've talked about, make sure that we're building into the learning activities and learning experiences the ways that we want students and the next generation of practitioners to be practicing. We do a lot of legislative advocacy as well, and so that's emphasized in school. So right from the beginning, we know that that's something that is expected of us as clinicians. So things like the Affordable Care Act, the whole of pharmacy, like groups and professional organizations supported with a unified voice, which is a powerful level of support. We pushed for the ability to immunize patients and get some of that routine maintenance type care done. And so now pharmacists in all 50 states can provide immunizations. Used to be just 18 and over. Now we can do flu shots in kids as young as, I think, something like 6 months. And then prescription drug monitoring program support. So in Kansas, that's K-TRACS. Basically, it's a controlled substance registry, which just recently added a lot of functionality that assesses patient risk for overdose. And speaking of, pharmacists in Kansas can also provide access to naloxone without a physician involved. So this is the Narcan, or the reversal agent for opioid overdose, and is really important in saving lives. So a couple action items here at the last couple of minutes I have straggling left. So these are the couple of kind of textbook academic things that we know help address the effect of our implicit bias. So individuating, looking at our patient as a one patient and not a group, not this bin of, I recognize this pattern, let me put them in this box. Also perspective taking, which is much easier said than done, but imagining yourself truly as the patient in their situation and not just kind of the regular garden variety level of empathy, but what it really means to be empathetic. So these are the things that we know kind of help mitigate the effects of implicit bias. There's a few more here that I think we can do at the individual level. So adjusting our rhetoric to eliminate alienating language. So that's kind of a mouthful, but what it means is we shouldn't be saying even simple things like, is this your husband? We should be saying, really, if you don't want to put your foot in your mouth, who is this in the room with us that we're talking to? But words like spouse instead of husband, sibling instead of son or daughter, this kind of helps address genderized issues that tend to erase patients and their needs in the healthcare system. We need to get really good at apologizing, which I think is something that we're lacking. So not just, I'm sorry, but also I'm sorry, because that tends to be omitted from a lot of apologies. I'm sorry, here's what I did, I take responsibility for that thing, here's how I'm gonna make an effort not to do it again. So that comes in handy in those situations where you do put your foot in your mouth and you learn not to do that thing again in the future, because it's embarrassing, but it also does harm patients. Building implicit bias training into educational efforts. So take the implicit association tests that Harvard offers, play with those, have your students do it, build it into their rotations and their different educational activities. I don't want to like spoil too much about what that test is if you haven't taken it, because it sort of gives it away, but go take it and challenge yourself, and then be transparent with those results and working towards kind of fixing them. And then develop a more diverse workforce. We know that if your workforce is diverse, it is the best protection against harassment and discrimination. And it also is one of the best protections for our patients to make sure that we're thinking about things in a multifaceted, minimally biased kind of way. And I managed to be like right on time-ish, but unfortunately, I don't know how that affects questions. I'm happy to entertain them.
I have a question for you.
Yes.
You have multiple interventions and actions that you're working on.
Yes.
What is the process improvement and metrics that you're following, and what numbers can you provide in terms of what is that part of the program? How good are you at your longitudinal follow-up and interventions? For instance, how frequently can you successfully get the patient medication you've done insured?
So I don't know.
And if they do.
Sure. I don't know if you all could hear remotely, but the question was basically, what kind of follow-up are we doing, and how are we making sure that that our interventions are useful and meaningful and kind of closing these gaps? And so I'm trying to flip through without like being too flashy here about which ones we're talking about. You're talking about some of like these items?
Yeah, I mean, you intervene. What is the success rate, and what do you do to improve or change?
Yep. So some of those things that we do as pharmacists actually are monitored by the government. And so, for example, retail pharmacies have something called a star rating. And so patient adherence is monitored and reflected in the pharmacy's star rating. So how well we're able to manage certain chronic disease states. In particular, that's things like dyslipidemia, hypertension, and diabetes, I think, are the big ones that they're looking at. And so we know through various studies that, for example, medication synchronization does help with those. I don't, have the numbers in front of me, but we know that that is an intervention that has statistically significant, clinically significant results.
But do you know that in your facility you're at 100% medicine?
Oh, so yeah, so that's like a retail level intervention. It's not something that we do at the hospital. So at the hospital, the way that we do that is we have one of our pharmacist specialists at like the leadership level is someone called our clinical coordinator. And she is, first of all, amazing, but second of all, that's her whole job, is to perform evaluations, to follow up on results, to look at the interventions that we're performing and make sure that they're actually achieving results. So we kind of all take ownership of those processes, making sure that, if I think something is a good idea, well, that it might be a good idea, but if it doesn't give me results that are patient-centered in some way, then it's really not that meaningful. So what we do is we perform a lot of times in the form of medication utilization evaluations. So we look at chronologically, last year it was like this, we implemented our intervention kind of like a clinical trial. What kind of outcomes did we see change? And unless we're doing those kinds of efforts, we're not going to know that it was meaningful in the first place.
And how is that reported to medical staff and others? Because within pharmacy, I'm sure you're very aware of it.
Yes.
How do you create that transparency to the rest of the system, especially to administration?
Mm-hmm. So the question was how does that information get dispersed throughout the health system so that we kind of know what we're doing and how effective it is. So we have the benefit of something, and this is one of the committees that is extremely useful, but Pharmacy and Therapeutics Committee is a really important tool for pharmacy in general. And so it's P&T, and represented on P&T committee are not just pharmacists who are non-voting members of the committee here for some reason, but also hospital leadership, physician representation, our residents, the medical residents are represented on that committee, infection control, all sorts of interdisciplinary groups are represented on P&T. And so we take those studies and evaluations to P&T, we disperse it to them. The hospital gets a newsletter about our activities there, and we participate in the kind of A3 analyses that the hospital does. So if there's an intervention that we found to be useful, that was cost savings or otherwise useful, we put that into the hospital's machine. I'm not sure there's a database for it, and then that gets dispersed. Anyone in the hospital can access it. Yes.
Do we have any other questions? Okay, well, I want to thank Dr. Nasra Zadani. This has been amazing. What do you guys think about the technology? And we want to thank Lucy Kohoff for her help, and the IT person in Selena as well for helping make this experience and all your support. Great presentation. And now I'm going to turn the microphone over to Jennifer Keaton. The microphone. Actually, I'd just like to introduce our Executive Vice Chancellor, Dr. Robert Samari, who's going to share a few words on behalf of the university.
Well, thank you so much for being here today. Such a health literacy, such an important topic when we think about the diversity of the components of our clinical environment and our education and learning environments, that to be able to understand each other in terms that are shared knowledge is so very important. So I appreciate you being here at this third Diversity and Inclusion Symposium. I know you've had a big morning, and I know that I'm the only thing that separates you from lunch. And so it's important not to stand in the way, but I really want to thank everybody for doing this. It's been an important few days for us on the diversity and inclusion side. Yesterday we had a small event where we discussed in some really important terms inclusion on campus, diversity and inclusion on campus with regard to the recent events in New Zealand, and really pointed out the fact that we witness the world through our own eyes, and it's easy to be stuck in that framework. But there are a lot of eyes on our campuses and our clinical environments, and to understand them through the eyes of others and through the literacy of understanding the cultural competencies of others is so important. So thank you so much for coming. I look forward to the afternoon, and I think, as they say, the buffet line is open. Is that right?
That's right.
All right, thank you.
Thank you, Dr. Saman. So
As our leader said, it is lunchtime and it is catered by the Taste of Brazil. So we'll take a few moments for people to start getting lunch, to get our next group of speakers, and it's not a panel, it's actually 3 short presentations. They've been gracious to agree to present during the kind of lunch. It'll be interesting, but we'll go ahead and ask people to begin serving while we start getting them set up. And I'd be remiss if I didn't recognize my boss, the Vice Chancellor of Academic and Student Affairs, Dr. Klein, in the back of the room. So thank you for being here. Okay, first in line.